Hey, everybody. Last review. We'll go ahead and get started. We'll try not to keep you guys all day. I'm going to start off. I'm going to go ahead and do the repro stuff, and then we'll take a break, and Lindsey will do the endocrine stuff. So let's just go ahead and get started. All right. As always, you know by now, the links to the YouTube videos are on the Scrubs page. They're private, so here's the link to your stuff. It'll bring you here. You can bookmark this page. Everything's here. The review we did yesterday is there as well. So y'all could watch it, go back if you feel like it. All right, so we'll start out with this. Breast pathology is not exactly my favorite. I find that a lot of this stuff is very similar. So I'll just kind of point out some of the differences. I didn't find it that it was highly tested, but we'll go through some of the pathologies here. So it kind of goes through the normal breast development here and structure, which you've learned already. But one of the big things, any sort of infection and mastitis, a lot of times you're looking at the prototypical staph and strep infections. That's what you would expect there. And then you can get ductictasia, dilation, these lipid-laden macrophages, which are common anytime that the macrophages are eating up lipids. I don't know that this was super tested either. What we want to get to, we'll first do fat necrosis as well, of course, just because of the area there. Again, not super tested. But what we want to get into is the different tumors. So first thing, you want to differentiate the stromal tumors from the epithelial tumors. So these two stromal tumors that we want to talk about are fibroadenoma and these phylloides tumors. Okay, so we want to differentiate these. First off, they're in the stroma, so they're not in the duct or the the epithelial portion of the breast. So that's going to be your first differential there. If it says that in the question. So these fibroadenomas are pretty common. They're benign. They happen bilaterally, which is an important. It does actually have an epithelial component to it versus the phylloides tumor is strictly stromal. So this does have an epithelial component, but compared to some of the more invasive breast tumors, this one's not so bad. Very importantly, you want to differentiate these. Are they estrogen sensitive or not? If they are estrogen sensitive, you would expect to see them, premenopausal women, okay, and reproductive ages. All right, so some of these are just those pathological descriptions, well circumscribed, which would be more of a benign type of tumor, rubbery grayish. Let's see, as for these, honestly, I think these histology slides, most of them look the same to me. So it's kind of hard to differentiate. And then you have these phylloides tumor. Phylloides means like leaf-like. So that's what you're looking at there. This is going to be happening more postmenopausal, 6th decade. So this, you can see this, the differential. So both have a stromal component, the fibroadenoma and these phylloides tumor. But you could see that this is a higher cellularity, higher mitotic rate, nuclear pleomorphism. So it's more of an active tumor. See this leaf-like, if they give you that and it's a stromal tumor, you definitely want to go with the phylloides. Bulbous protrusions, does have an aggressive behavior. So it can spread, it can metastasize through the blood. Okay, versus those fibroadenomas are pretty dormant. So I don't know that this is super important, this classification, but obviously the more mitotic, the faster the mitotic rate, the faster the cell turnover, the more malignant potential it's going to have, okay? Then we want to get into the benign epithelial lesions. So these are going to be more of the ones that you commonly hear. Certain things that, we'll get there in a second. This is more of like an overview, right? So atypia, meaning are the cells normal looking or do they have atypia, atypical shapes or, sizes and stuff. Typically any sort of atypical cells are a bad thing, right? So let's just go through these. So just some definitions, there's cyst, fibrosis, and then this adenosis that you could see here, globular enlargement, increased duct size. Aden always means glandular, right? So glandular growth there. So these atypical, so there's increased proliferation, increased mitotic rate, but you would expect the cells to look normal, right? So with these epithelial hyperplasia, you'll see sclerosing adenosis, right? So this sclerosing is, in my mind, is kind of like fibrosis, it kind of goes together. Plus you get the glandular growth as well, the adenosis. So sclerosing adenosis is a common thing that they talk about, but when we get to the specific tumors, we'll talk about that in a second. Right, so, and then there's intraductal papillomas, right? These epithelial growths, right, into the papillary structure. Yeah, they could be large or small, either way. All right, and then you have atypia. So these are going to be more aggressive of the tumor, ductal versus lobular, and we'll get into that in a second. Here's a nice little slide that kind of, if you're down to the wire, just going through these will help you differentiate these, okay? So fibroadenoma and phyllodes tumor will be your stromal tumor, okay? Right, fibrocystic change, premenopausal, you will get this fibrosis and sclerosing adenosis, but this isn't really no risk for cancer, okay? This fibrocystic change, and then you can get intraductal papillomas as well. All right, I think the second one goes into the more aggressive tumors. But again, I find that these are very, they sound very similar. They look very similar. So at the end of the day, when it comes down to these, a few buzzwords that differentiate these from each other is going to be good enough to answer these questions. All right, so you can see the normal unit and how it actually works, the stromal tumor, the phyllodes versus the invasive ones, which we're going to get into now. All right, so, right, this is just an introduction. Right, very importantly, these different genes that are going to be responsible for these, specifically the BRCA genes, which you are familiar with. They have breast cancer potential, but also ovarian cancer. Then some of these other ones, we talked about Peutz-Jeghers syndrome yesterday. Li-Fraumeni has to do with P53. So you get because P53 is so active in the body, you get an array of different types of cancers. But by all means, for this breast cancer lectures, these BRCA mutations are going to be the most important to know. You can see here some of these aggressive tumors that metastasize, can go to the bone, brain, liver, or lungs. Very importantly, remember the question they ask about peau d'orange is the ligaments, okay? So the ligaments are what are affected, and that's what actually give this, this peau d'orange appearance. Let me read this. Okay, good, yeah. Right, so in situ means that it's not invasive yet, but it has the potential of getting to that point. It's like pre-invasive stage. Calcifications, you would expect that. All right, so they haven't broken through the basement membrane, so they don't have access to the blood vessels or lymphatics yet. You can see some of these calcifications here. All right, let's see. All right, so lobular in situ, right? In situ, one of the big buzzwords here is that ecadherin. You want to make sure you know this, right? Because that's going to help. That's going to be one of the diagnostic clues that you're talking about lobular carcinoma. They also get these signet ring cells, which are common. It pushes the nucleus to the side. Can't really appreciate that here, but let's see. And then Paget's disease. Right, you get this, it's this epithelial lining here, so you get this, kind of looks like it's dried over. So you can see here, these are malignant cells of the epithelium. Okay, so a lot of times that's a good way to differentiate it or to kind of picture it in your head as mistaken for eczema. It looks like it's dried over skin. And you can see that it's not estrogen responsive, but you do have an overexpression of HER2. So if they talk about it, Paget's disease of the breast, don't get it confused with that peau d'orange, because they kind of look, remember peau d'orange has to do with the lymphatics, okay, and the Cooper's ligaments. And And then you have the invasive, so once it as the in situ goes, it becomes invasive. So increased mitotic rate, now it has access to be able to spread. Again, with this lobular one, the E-coherent is going to be one of the differentials to answer these questions. Medullary carcinoma. So now we're talking about, this has a BRCA1 association, non-estrogen. Okay, so it doesn't really have these markers that you're interested in. Non-progesterone and non-HER2 negative as well. You can see this poudre orange appearance with this orange peel appearance, but typically no inflammation is present, which is kind of a misnomer here because it is inflammatory. And then, yeah, I put a star on this slide. I obviously put a star on this before the test when I was going through my notes to remember it, but looking at it, I'm not sure that this was a highly tested point, knowing these different variations, but I would say it's fair game. Then you have prognostic markers, of course. Big thing is there any metastasis? So you want to check those sentinel nodes, and then you could also go through this, estrogen, progesterone responsive, all that stuff, HER2 responsive. And that'll kind of tell you how aggressive it is and what kind of treatment you can use. And here's your medication, your management or your that you'd like to use for this. Right. So if there's some sort of estrogen positive, pretty sure there was a lecture. I'm pretty sure y'all had a lecture as well on medications, or maybe that was a term 5 thing. If y'all did do it, we'll get to it in a second. All right, so male breast, it's obviously not as common as female breast, but some medications will lead to gynecomastia, Klinefelter syndrome as well, estrogen therapy, stuff like that. All right, and of course there's risk factors for that, but that's definitely not super important. And now again, we have a summary slide. So the summary slide before plus this one will help you differentiate these. Remember Paget's disease, lactiferous ducts, for sure. You definitely want to keep that separate from the poudre orange because they ask about what the different, what's the causality of those to be able to differentiate those. Okay, we talked about lobular carcinoma. Look, you could hear, and that's one of the things they like to ask. BRCA has to do with medullary carcinoma, among other things, and you can see that here. All right, so good summaries there. Again, I wish I had better knowledge on the breast pathology, but like I said, I find it kind of a lot of the stuff very similar, and but again, it's not a super tested point. I think they all appreciate the fact that it's very, a lot of those tumors, at least in histologically, are very similar looking. All right, so we can move on to the prostate. Big thing here is to be able to differentiate BPH from prostate cancer. Remember, BPH, they're going to come in with urinary symptoms, okay? Because the growth is centralized. It's around the urethra, or around the urethra. This transitional zone, the central zone. So it's actually squeezing down on the urethra. So they're getting urinary problems. With prostate cancer, this is why they do digital rectal exams, because a lot of times it's found incidentally. Okay, a lot of times because of the location in this posterior lobe of the prostate cancer, you won't necessarily get urinary symptoms until it's very advanced. Okay, so that's a big thing. Don't necessarily see, or at least if you do see urinary symptoms, lean towards BPH. Okay, because they will give you questions with prostate cancer with urinary symptoms, but in real life, it's very, it has to be advanced, okay? And that's just due to the proximity of where they lie, okay? So BPH, again, is centralized over the urethra, where the prostate cancer is on the outside. Now, they both get, have enlargements, but when they talk about prostate cancer, when you do the digital rectal exam, they talk about it as nodular and hard, okay? So that's usually indicative of prostate cancer. Okay, so you may not necessarily get urinary symptoms with prostate cancer, but you will get it with BPH for sure. Okay, another thing you can check with BPH, you kind of get a slow rise in your PSA. Okay, your prostate specific antigen. What you want to look at for prostate cancer is a very rapid spike. Okay, so the patient comes in for, you know, their yearly, and their PSA goes up dramatically, not incrementally, over time, then you're worried about prostate cancer. So you will get a rise in both, an elevation of both. But with prostate cancer, it's more of a spike you need to be aware of. So prostatitis infections, again, E. coli, big one with UTIs. So prostatitis is a thing there. You can get an elevated PSA with that too. So you need to be aware of that. Get a urinalysis. You can see if there's any sort of bacteria in the urine. Okay. Again, BPH, voiding problems, storage problems, because of where it's located around the urethra. Okay. Okay. Let's see. And then again, with prostate cancer, you're thinking more of the peripheral zone, and you're worried about, you know, growth in that area. So that's why they do the DRE, because they can see if there's a nodular appearance to that. Okay, so one of the treatments you can give for this is a 5-alpha reductase. Remember, 5-alpha reductase converts testosterone to the more potent DHT. So a drug like finasteride will help to prevent that. And so if you don't have that really strong DHT, you're going to kind of decrease the possibility for growth, because it can be testosterone dependent. And it gets a little more complicated, because actually what happens, I mean, I think I'll get into that in turn 5, you actually get more estrogen when you're older, so you get more DHT receptors. And because of that, that DHT is more potent on the gland. So the idea here is, even though you have more DHT receptors, if you can inhibit the total amount of DHT being made, then you could prevent this BPH growth. All right. So prostate cancer, we know it's glandular, so you worry about these adenocarcinomas, hard consistency, multiple nodules, okay, usually found on DRE, peripheral zones here. And you can see it's really hard to appreciate still, though. I guess this area here looks a little bit different. Yeah, now another big thing about, due to the location and the drainage, a big thing with prostate cancer is you get these metastasis to the spine. Now they're osteoblastic, so that it's different. It's not osteolytic. Okay, so things like multiple myeloma pull calcium off the bone, so you get these lytic lesions. This is, with prostate cancer, it's osteoblastic. Okay, so you actually get these bony calcium deposits. Okay, osteoblastic or osteosclerotic, you're actually putting these calcium deposits in the bone, and you can kind of see those in here. So it's different if you would look at this on an X-ray. These are dense deposits versus lytic would be more of an empty space. So remember, prostate cancer will lead to these osteoblastic deposits, particularly in the lower vertebral spine. Okay, I think that's all for that. All right. Disorders of the testes, cryptorchidism, typically, you know, that means undescended testes. It's dependent on testosterone. So if there's some sort of testosterone imbalance, the gubernaculum won't be able to pull the testes down. Problem with that, infertility, but it can also lead to cancer as well. Okay, so germ cell tumors can develop if they're undescended as well. So then they went ahead and went into these testicular tumors. Let's see, these are some of the complications. And then, so germ cell tumors, seminomas are one of the ones you really need to understand. That's the problem. I'm pretty sure we'll get to it. I'm pretty sure that's the one that develops if you get cryptorchidism. You get a seminoma. You can get a seminoma. Let's see. So some of these buzzwords, fried egg appearance, even though that comes up a lot, but yeah, that's one of the things. Originate from the seminiferous tubules. Obviously, it's a germ cell tumor. Some of them will show elevated beta HCG, but that's not necessarily determinate. Can somebody confirm for me? I'm pretty sure cryptorchidism, you're worried about development of a seminoma. I'm pretty sure that's what it is. But somebody correct me if I'm wrong. All right, then some of the other ones we're worried about, some of the, you have embryonal tumors. So again, these will be more of a primitive development. These cells, primitive cells, not as important as the seminomas, but poorly differentiated glandular tissue. I don't think that was very highly tested. Yolk sac tumors, big thing here, secrete alpha fetoprotein. So we talked about yesterday, hepatocellular carcinoma will secrete this alpha fetoprotein. Yolk sac tumors do it too. So you definitely need to know that as a diagnostic clue for these. Also a buzzword here, these Schiller-Duval bodies. That came up a lot in term 5 on those board style questions. So Schiller-Duval bodies, alpha fetoprotein, you want to think yolk sac tumor. And you see that development in kids. All right, contrasting that, if you were to see a elevated beta HCG, you want to think of choriocarcinoma. Okay, anytime you have elevated beta HCG, you need to think that syncytial trophoblasts are involved because those are what secrete beta HCG. Okay, so this choriocarcinoma involves syncytial trophoblasts and cytotrophoblasts, which primarily deal with implantation and stuff. But since we're talking about men, it still can develop in these sort of tumors, so you get beta HCG. All right, so teratomas, also you know about those. These are those mixed cellularities. You can get multiple, all 3 germ cell, epi, meso, and endodermal components to it. So these can show skin, hair, teeth, stuff like that, but it's obviously more common in women, but you can get it in guys. All right, so again, big thing here, alpha fetoprotein, Schiller-Duval bodies, you're thinking yolk sac, beta HCG, choriocarcinoma. Okay, then you know these by now, hypospadias. Remember when you're talking about the anatomy of the penis, the penis has to be erect. So if the penis is erect, the front side or the bottom of the penis is ventral, the back side is dorsal, which is the top, you know what I mean, right? So and I'm telling you this just because that's how they define these. So at P spadius, the way you remember this, the way I remember it is you pee in your eye, right? So it's technically on the dorsal side of the penis, which is the top. So that's where that hole is. So you at pee in your eye. Hypospadias is on the bottom of the penis, which if erect would be technically the ventral side. Okay, so make sure you have those straight in your head because that's how they define it in the question. Okay, then there's some other ones. Phimosis, I don't think that came up or anything like that. And then of course, genital warts, HPV 6 and 11 are the wart kind. And then what are the other ones? They come up. Yeah, 16 and 18 are the invasive ones. Obviously, you're more worried about this in females. 6 and 11 and then 16 and 18. Right. I think 31 and 33 come up too, but not here apparently. I highlighted these, but I don't think they came up, so I don't know that you really need to know that. Right. Yeah. And then this HPV infection can develop to squamous cell carcinoma penis, but not super common. These cancers of HPV take a long time to develop, so it's just not very common to get to this point. All right, so let's go through some of these hormones. You know these by now, coming from the pituitary, LH and FSH, coming from the hypothalamus, GnRH, the GnRH signals to these in the pituitary. To release, they go down to the genitals, to the testes, and cause sex hormone release. Okay, so you know all this by now. Remember, inhibin comes from the Sertoli cell. So the way I remember it, luteinizing hormone helps to make testosterone, but follicle stimulating hormone helps to make sperm, S for sperm. So if you can see here, once the sperm's developed, the Sertoli cells can secrete inhibin to feed back on FSH and LH. to kind of say we have enough. You can stop signaling. But again, Sertoli cells also has an H, and Leydig cells has an L. So LH goes to Leydig cells, FSH goes to Sertoli cells, and then, yeah. And then we go into the female development. So same kind of principle here, but then the LH will go to the theca cells, and they'll get to make androgens, and then the androgens are shunted over to the granulosa cells. You use aromatase, which is a big enzyme to convert these androgens to estrogens, and these are in the granulosa cells, okay? So keep those straight in your head. Let's see. Okay, so you know by now, one of the big effects of estrogen is that they inhibit osteoclasts from breaking down bone. That's why postmenopausal women tend to get osteoporosis. They don't have that inhibitory estrogen effect on those osteoclasts. So the osteoclasts kind of eat up the bone. See some of the other effects too that you can see here. So if the osteoporosis or menopausal symptoms are bad, you can give some sort of estrogen replacement therapy. For that, let's see. All right, and then we go into more of the medications here, which is what this lecture is about, or this DLA is about. You need to know the differences here. So tamoxifen is specifically an antagonist on the breast. So if you have estrogen receptor positive breast cancer, you can use tamoxifen. The problem with tamoxifen is it's an agonist on the endometrium. Okay, so it can lead to endometrial proliferation or even cancer there. So that's a problem. So what could you give instead? Well, you can give raloxifene because it's actually an antagonist on the uterus and the breast tissue. Okay, it actually works out really well because even though it's an antagonist on the breast and the uterus, it's an agonist on the bone, which will prevent osteoporosis. So it actually works really well in that regard. Again, so you can block this estrogen response in the uterus and the breast, but you can still get this effect to where it will block those osteoclasts and you won't end up getting osteoporosis. So enclomiphene is very commonly used in vitro fertilization. It's an antagonist at the hypothalamus, so it'll work on GnRH. Okay, so big takeaway from this lecture, or this DLA, is differentiating tamoxifen and raloxifene. Again, like I said, no risk of endometrial hyperplasia because raloxifene will not only inhibit estrogen at the breast, but also at the uterus. Now, last line, if all this is not going to work, fulvestrant is just will basically block, it's a hormone receptor, it'll block estrogen everywhere, is my understanding of it. It's an antagonist on all tissues, okay? So there are consequences that come with that, but it's my understanding that this is kind of a last line treatment if the other medications aren't working. Now, aromatase inhibitors, you can see here. So this will prevent the conversion of androgens to estrogens, like it was in the granulosa cells. Similarly, but this is peripheral conversion, okay? So if that's the case, you're not gonna make too much estrogen. Consequently, you have more androgens floating around, but the whole point here is to block estrogen formation. So this is another option. So commit these to memory as well. I know if it's super important knowing which ones are competitive or reversible, just make sure you know those are aromatase inhibitors. Progesterone's also an option here. You can see these used in birth control. Yeah, right. And of course, progesterone is the pregnancy hormone, as you know. So to maintain pregnancy, you have to have elevated progesterone numbers. All right. Main thing here, used in oral contraceptives, usually combination pills with estrogen. Mifepristone is used as a abortifacient. Remember, we talked about misoprostol yesterday. You can use these in combination, and it's abortifacient, so you can use that. It'll block progesterone. Mifepristone will block progestin or progesterone. So if that's the case, it'll terminate the pregnancy. And misoprostol is used as well. Right here, so we have androgens that can be used, testosterone, danazol, and we can convert, as we said, remember this is like aromatase is important to get estrogens, 5-alpha reductase is important to get DHT. So if there's some problem with forming testosterone or non-development of secondary sexual characteristics, you can give androgen replacement therapy there. All right, and you can see that here. Right, hypogonadism is a good one. Right, and then of course, people use this, illegally for, anabolic steroids and stuff like that. And then danazol, a side note, it has anti-androgen effects. It's an estrogen or an analog, so you can use to treat endometriosis and fibrocystic change. All right, so the adverse effects of androgen are what you would expect: masculinization. You can also get menstrual irregularities in females, right, and stuff like that. Gynecomastia, you may ask why. Well, if you have increased androgens, you are going to get increased peripheral conversion to estrogens as well. So it can lead to gynecomastia. Gonadal atrophy, they talk about this when people use anabolic steroids. If you're using exogenous testosterone, you're not making your own in your testes, so they will atrophy. Just like the adrenal gland will atrophy if you use glucocorticoids because you're not using cortisol. You have to constantly make it endogenously to grow. So if you're using it exogenously, you're injecting it or something like that, the normal area that would be making it, in this case, the testes, will atrophy because they're not being used. Okay. And then you also have antagonists, which are very important because if you want to decrease the amount of testosterone going on, flutamide, prostate carcinomas, you don't want a lot of extra testosterone, so it can treat these prostate cancer. Spironolactone, we know that is a potassium sparing diuretic. It also has anti-androgen effects. So one of the side effects of using it for diuresis is the fact that it can cause gynecomastia. Okay, so I don't know that it's first line in this case, it's more of a diuretic, but yeah, it does have anti-androgen properties as well. These are going to be important. We talked about 5-alpha reductase, so BPH is the big one that you're going to use there. Again, DHT is very potent, so if you can prevent the conversion to DHT, you can help with BPH. And then ketoconazole, not really used in my understanding for this, more like Cushing syndrome. Maybe it's that first line when you're converting cholesterol in the adrenal gland. Okay, so you can kind of stop everything at that point, and the downstream. We talk about this with those CAH in kids, the CAH deficiencies, but I don't know that it's super important in prostate cancer here, but just make sure you know it. Yeah, so adrenal and gonadal steroid synthesis. It's just kind of very high up in the pathway if you look at that adrenal synthesis. So you're going to prevent conversion to aldosterone, cortisol, and the sex steroids. So there are consequences that come with that. All right, good. And by all means, if y'all have any questions or I say something incorrectly, just feel free to stop me and we can go through it. I don't have the chat up right now. All right, so normal anatomy, you know this. We'll get into the different pathologies here of the ovary. Big one they like to test on, these chocolate cysts. So endometriosis is the growth of endometrial tissues somewhere else. The most common place you can get this endometrial growth in a non-endometrial endometrial growth somewhere not in the endometrium would be in the ovaries, right? And that's where you get these chocolate cysts. Okay, so it can lead to infertility, which makes sense because you don't want endometrial tissue growing in the ovary. All right, so they like to test on this. this chocolate cyst is indicative that you have endometriosis. All right, and here's another one, PCOS. They like to test on this too. So we're going to kind of break this down. One of the major things, and I think it's one of, my understanding is that, you have like a combination of things going on that produce this whole problem. So one of the big things they test on that may not seem intuitive is that one of the insulin resistance is a huge component to this, a huge primary component of the downstream effects. And it may not seem intuitive because we're talking about the ovaries. What does it have to do with insulin? But it actually leads down to this, all of these compilation of symptoms. So things that could lead to insulin resistance, such as obesity and type 2 diabetes, can end up producing PCOS. So you get this increased insulin, which insulin has a ton of different characteristics. One of which is to increase androgens. Now, people with PCOS, with these increased androgens, you're going to get certain things like hirsutism, you're going to get hair growth or a deepened voice because of these increased androgens. Now, you're also going to get increased GnRH secretion. So you see these are kind of like separate entities here, and by putting them together, you're getting this mass effect, right, of this increased androgens. So what you'll actually see is a very much elevated LH. And don't get this confused because it says increased LH to FSH ratio. If you were looking at the labs independently, you would get an increased LSH and a decreased FSH. Now, that in and of itself would cause this increased LH to FSH ratio. But I've seen questions where they give you the up and down arrows and they're asking you independently. You do get a really high LH and you get a decreased FSH, okay? And you can see this, the reason the FSH is decreased is because you get this unopposed estrogen secretion, which will feed back and decrease this FSH, okay? But LH will be very much elevated. And the reason you're getting this feedback of estrogen is because you have so much androgens, you're getting conversion to estrogens, okay? So that'll feed back to decrease FSH. Again, so if you're looking at the labs, you'll have an increased GnRH, increased LH, and a decreased FSH, okay? Now, if you looked at this over time, you can see there's no LH surge. So you kind of get this constantly elevated LH over the month. So you don't actually get that ovulatory spike. So you won't get ovulation, no corpus luteum, no low progesterone, so no feedback on estrogen. So this is this whole combination of things, but major things you need to remember: insulin resistance, increased GnRH, increased LH, decreased FSH, increased androgens. This is all a combination that will lead to this. So you get hirsutism and acne due to all that increased androgens. With that conversion to estrogen, you'll get endometrial hyperplasia. With the no LH surge due to the tonically elevated LH, you won't get ovulation, so you won't get so you'll be infertile. So these are the three things that that you definitely want to know about this. All right, and this is what I was talking about. You get this constant, rise in LH, so you don't have this surge. Okay, it's just tonically elevated. So this is indicative of PCOS, and FSH is low. Okay, due to that feedback. All right. But definitely important to know, right? So we kind of went through this. One of the things they talk about diagnostically is the string of pearls. You can see that on ultrasound, but you're looking at those cysts in the ovaries. All right, so we'll go through the tumors. Again, these get confusing as all tumors do, so try to find a few things, one or two, that will help you differentiate these from each other, okay? So yeah, fallopian tube will be serous, endocervical will be mucinous, and then these non-ciliated columnar cells will be endometrioid. Don't know that it's super high yield. I'd call it fair game though, if being able to differentiate these. So commit those to memory. Kind of goes into the different complexity and the severity of the growth. So again, so let's review. We said three big tumor markers we need to remember. We talked about CEA yesterday. That is for colon cancer. We talked about C19-9. That is for pancreatic cancer. And now we're talking about CA125. That is going to be diagnostic for ovarian cancer. Okay, so you definitely need to know all three of those. They use those clinically to make these diagnoses. And here you can see that here. So any sort of carcinoma of the ovary can lead to this increased CA125. Right, so start this. So this kind of, like we were looking at before, kind of goes into the different types of epithelial tumors. Knowing the location is going to be a good first step, like that previous slide had. And then severity, I think knowing where they are and a little bit about the epithelium will be good enough there. All right, and with all these serious tumors, you get inhibition of these tumor suppressor genes and these oncogenes that are seen in all kinds of different tumors. So you can see those here as well. Yeah, so you see culprits, P53 and RB as well. Those cell cycle check regulators. Also has BRCAs, these mutations here. So watch out for that. And then we go into the serous ovarian tumors. Sonoma bodies, which are basically just calcification. So you see those in a bunch of different tumors, brain cancer and stuff like that. And then you can see they're involved, BRCA is involved in the serous ovarian tumors as well. All right. Goes into the different types. Then mucinous has KRAS. So again, these are very diagnostic buzzwords or clues into what we're looking at. You could see this pseudomyxoma peritoni, which would make sense because this is increased mucus buildup in the abdomen, where we're talking about mucinous ovarian tumors. So that would make sense. So make sure you have those together, keep those together. And then you can see this mucin buildup as well, columnar cell line. Yeah, so jelly belly, mucinous ascites, right? Mucinoid tumors. Keep those together. All right. And we'll keep going with these. Now, these endometrioid tumors, P10 is involved, microsatellite instability. So you have a problem with mismatch repair. You're not able to fix your DNA mistakes. So that could lead to cancer. You could see KRAS was involved, I believe, in the mucinous we saw, but P10 and P53 are involved specifically in these clear cell endometrial tumors. Transitional cell, remember transitional endothelium is specific to the urothelium, the bladder and stuff. So if you see transitional cell, you would expect that to be in the bladder, or it could be a metastasis to somewhere else, but it's bladder tissue. Okay, so it resembles the epithelium in the urinary tract. All right, and then those weird germ cell tumors. Yeah, you just, again, same thing, just try to get a couple of words here and there that'll help you differentiate. These diagnostic clues are going to be important. Again, teratomas, they're going to have 3 germ layers, endo, meso, and epithelium. Yeah. Yeah. And so ectodermal, endodermal, and mesodermal, right? So they could have all 3 components, and you can end up getting with these, hair and teeth-like structures there. So again, teratomas can have all 3 germ cell layers. Can transform to squamous cell carcinomas, 1%, so not super important. Again, we talked about these in the men. In women, alpha-fetoprotein still elevated yolk sac tumors, Schiller-Duval bodies. That's what you're going to want to keep in mind. For now, I think the questions will literally just say, you see the presence of Schiller-Duval bodies. Going through a lot of these practice questions now, sometimes they won't give you this word and they'll actually define it. and you're supposed to be able to know it. But for now, I think it's okay just knowing that this word, the Schiller Duval body, correlates to yolk sac tumors. But some of the more difficult questions, they won't tell you. They'll just kind of explain it like this, and you're supposed to be able to put it together. But yeah, y'all will get there. This germinomas, you can see these markers that are involved here, LDH and HCG, gene involved c-KIT. Choriocarcinomas, just like in men, you would expect to see an elevated beta-HCG. Okay, chorionic gonadotropins are going to be elevated there. So where does it say? I don't know that it says it directly, but you are looking for elevated beta-HCG for this. All right, then there's sex cord tumors. So you're looking at granulomas, thecomas, and Sertoli-Leydig cell tumors. Granulosa cell tumors, you'll see this large amounts of estrogen there. Call-Exner bodies, that's kind of another one that they'll talk about there. So for these granulosa cell tumors, you're looking for these Call-Exner bodies, and the tumor marker, you're going to get elevated inhibin. Why elevated inhibin? Well, inhibin is made by these granulosa cells, right, to feed back on FSH. So you're going to get elevated inhibin. So if you see that, correlate that with these granulosa cells. Thecomas or fibromas, you can see that fibroma would make sense that you have elevation of fibroblast. Not sure that this is super important. Meeg syndrome, I think it came up in a question in board in the UWorld questions, but I don't know that I saw it in the SGU test. Yeah. Probably just go ahead and know that these go with these. Ovarian tumor, hydrothorax, so fluid buildup in the thorax and in the abdomen. Yeah. Then you get these Sertoli-Leydig cell tumors. So you would expect hirsutism, male hair distribution, stuff like that due to the increased testosterone production, defeminization. All right, and then of course you always get metastasis. We talked about these Krukenberg tumors coming from the gastric cell. This is metastasis into the ovaries, I believe. Yeah, it's gastric origin. See this signet ring cell. So I believe it's gastric adenocarcinoma. If they metastasize, they can metastasize bilaterally to the ovaries, and you get these Krukenberg tumors, signet cell appearance. We talked about the pseudomyxoma peritoni, right? Mucinous, right? Mucinous buildup. So mucinous ovarian cancer as well. Yeah, I mean, I guess that's a good thing to know. Young, typically benign, postmenopausal has more of a malignant potential to them. Sure. All right, a good little review slide. Definitely know what goes with what. All right, so one more time, specifically yolk sacs, alpha fetoprotein, Schiller Duval bodies, granulosa cells, increase inhibin, Call-Exner bodies. There. Yeah, that should be good. Yeah, so know this stuff. All right, let's see. Yeah, we can go into these now. All right, so we'll go through these, all of the different STIs that we're looking at. Again, some of these present similarly, but there are small differences that will help to differentiate these. All right, so bacterial vaginosis is not technically an STI. It's from Gardnerella vaginalis. You get a loss of this protective lactobacilli, which is an acidic pH. So then you can get this increased growth of bacterial vaginosis. Right there. Big thing here to differentiate this, the secretion is gray, okay? Malodorous, fishy discharge. So the big thing here is that it's a gray discharge. They'll have to tell you that really to be able to differentiate it from some of the other stuff we'll get at. Some of these virulence factors, not sure they're too super important. What I remember some specifically saying it was gray and it was malodorous. Oh yeah, and the clue cells. Those are super important. And the vaginal pH, because you have that decreased lactobacillus, will be elevated. Pretty sure there's a summary slide that has all these once we get through them. But so increased vaginal pH would be indicative of this as well. Clue cells with tests, that just mean it's malodorous. It has an amine or a fishy odor to it. All right, yeah, same thing. Clue cells, malodorous, increased pH, gray discharge. Candidiasis, candida is a fungus. You would expect this in immunocompromised patients as it itches, burning, cottage cheese-like discharge versus the gray with the bacterial vaginosis. So candidiasis always has that white discharge. Right. Pseudohyphae, that's a very big characteristic versus different other fungi that have hyphae development. These pseudohyphae are specific, at least what we talk about, are specific to candidiasis. Note here that the pH is also elevated with candida as well. All right, so this is this is the slide I wanted to talk about. So if you were differentiating these two, bacterial vaginosis, white or gray, say gray, they should put gray so you don't get confused. Fishy smell, pH is elevated. pH is elevated here as well. I'm sorry, nope. For candidiasis, pH is decreased. So that's going to be a big differential there. Okay, so back to bacterial vaginosis, expect those clue cells. So we'll get to trichomonas. That is actually the STI. One of the STIs we'll talk about. It has a green odor, and it also has a foul odor to it. Strawberry cervix is what they talk about, but it also has an increased pH. So trichomonas is a protozoa. It's flagellated. It can move around. So be able to differentiate these by the color, the pH, and some of the diagnostic clues. No pun intended. All right, so look, you can see here, trichomonas, right? So it's motile, but it's going to give more of a greenish discharge. And you can see the strawberry cervix here. Yep, strawberry, cervical petechiae, green malodorous. So typically the questions I've seen, they've kind of just described it and they've asked you what it was, straightforward, okay? So just be able to know the differences there. This kind of goes into there's different stages. I don't think that's too important. Some of the virulence factors as well. I don't remember those coming up. Let's see. So you can culture these. They use the nucleic acid amplification test. Yeah. Right. And of course you can use the whiff test, the malodorous, and it has that similarly to Gardnerella vaginalis. It's like a fishy amine odor to it. Okay, so but as always, typically culturing is the best gold standard to do this stuff. All right, so now gonorrhea, gonorrhea and chlamydia typically go together. Gonorrhea is the most common STI, I believe, in the world. So you can see here some of the important characteristics of it. Again, it does co-infect. So typically if a person comes with gonorrhea, they just give them a combination medication to treat both of them. The problems here, if it's not treated, you can get disseminated infection, septic or gonococcal arthritis. Usually they talk about it as unilateral knee pain. Okay, so if you get this unilateral knee pain, sometimes it could be an STI, it could be gonorrhea. You could also get cutaneous lesions. And it specifically can affect this MAC complex. Remember, that makes those pores in the cell. So if you can't do that, it's really hard to kill the gonorrhea, the cells, the bacteria. All right, so you get this discharge, this white, yellow, or green urethral discharge. Same thing with women, you get this discharge as well. Vaginal discharge, yeah. Let's see. Diagnosis, Gram stain, And very importantly, you can use this Thayer-Barton auger that's specific to this. So you want to remember this for sure. And then diagnostically, you can use the nucleic acid test or PCR. All right, like we said, you can get the septic arthritis. It's usually unilateral knee pain. You could also get reactive arthritis. Remember, reactive arthritis is the can't see, can't eat, can't climb a tree. So conjunctivitis, urethritis, and arthritis. Okay, so that can cause that. A pelvic inflammatory disease that can often lead to ectopic pregnancies in the fallopian tubes if there's scarring there. And you can even go into this Fitz-Hugh-Curtis syndrome where you get right upper quadrant pain, fever, and chills with it. This does look familiar. I believe this does come up, so be sure to know that one. Yeah. Okay, and if you were to differentiate it from meningitis or meningitis there, but y'all are going to do that later. All right, again, co-infects, chlamydia here will co-infect with gonorrhea. Chlamydia is gram-negative, intracellular. Like I said, they usually treat these together. Yeah, can actually lead to conjunctivitis in the infants if the mother's not treated. And yeah, one of the big things with chlamydia that they talk about is the different life cycle, the different stages of the life cycle. They have this EB, I forget what the E stands for. Elementary body is the infectious stage, and I think it's the, is it the replicative reticulate body, and that's the stage that replicates. So this is very specific for chlamydia. If they ask you something, that's likely what they would ask you. All right. Again, you can use this nucleic acid amplification, this PCR test to work it. Same thing, you can end up with PID, which could lead to ectopic pregnancies, goes with gonorrhea for this reactive arthritis. All right, not very common in the US, these cankeroids. Don't know that they really ask you about this. It's rare in the US. Yeah, believe one of the big things with these lesions is being able to identify if they're painful or painless, because they'll tell you that in the question. I believe these, yeah, these are painful sores. These Ducree, I believe is how you say it. So these are painful sores, irregular borders, can lead to lymphadenopathy as well. Again, this is very low yield. They don't really ask about this because it's not very common, but you can do PCR to diagnose them. All right, syphilis, very important. It has different stages to it, so you want to diagnose this early before it gets to the stages, to the different stages, but we'll go through that in a second. This is that, they don't really use this. They, I forget what this is called. That light thing that they use. Phone a friend, anybody? Yeah, I forget. Oh, dark field microscopy, that's what it's called. Yeah, but I don't think they really use this. They don't have this. Isn't very common in certain hospitals. So they don't really use it too much. It's not like a diagnostic thing. I mean, it can be, they just, most hospitals don't have it. All right, so gram-negative, yeah. Spirochete. Spirochetes in general, just so you know, are gram-negative. So if you ever see a spirochete, just know those are gram-negative. Right, so transmission, body fluids. Congenital syphilis, you need to know that these different things are specific to it. Saddle nose, saber shins, these Hutchinson teeth is what they called, and sensorineural neural hearing loss. It's a big one for this. You can see that in some of the other things we're going to talk about, but keep that in mind. You don't get eye symptoms with syphilis. So that's a big differential from some of the other ones we're going to look at in a second, rubella, toxoplasmosis and stuff. So with syphilis, you're going to see sensorineural neural hearing loss, but you're not going to get those eye symptoms. Maculopapular rash, that would be indicative of, that's one of the signs of syphilis. And if it's in adults, if you get a rash, that's indicative that it's secondary syphilis. All right, but they should go into that. Okay, here we go. So primary syphilis, you get that canker, painless, okay? So versus like herpes is painful, that H. ducrei, whatever it's called, those are painful. These primary lesions and syphilis are painless. Now, once you get the rash, that indicates that you are secondary, okay? And you can get these condylomata, which are like genital lesions. But again, big thing here to remember, painless. Primary canker, painless. Rash is indicative that you're at secondary phase. And you can also get these lesions. Now, the latent development, if it's reactivated, that could happen as well. Now, once you get, if it's late or it's reactivated and it's tertiary syphilis, that's when you get it to all the whole systemic problems, neurosyphilis, tabes dorsalis, that's a big one there. So you get, I believe that's sensory loss. You can check me on that, but I think that's indicative of the dorsal columns, sensory loss, cardiovascular problems, stuff like that, okay? So again, syphilis, big thing, no primary, secondary, and tertiary. Know what congenital syphilis looks like as well. Okay, let's see. Diagnosis depends on the stage, okay? So like I said, you can do these dark field microscopies, but it's not really used a lot. What you can really use is these antibody stainings, immunohistochemistry, do PCR as well. I believe they go into this, which you really what they do is this non-triple mono test, and then after that comes back, then they do the triple mono test. Yeah, here it is. All right, so you do this one first as a screening test, the NTT, make sure you know this. That's the screening test that you can use. This VDRL test is the screening test, either one, the RPR or the VDRL, but it's a screening test. And then you can go and, because there's some false positives, or false negatives here. Let's see. Anyway, to make it a confirmatory test, you do the triple mono test. And by doing that, then you use antibodies, this FTA, ABS. So you should know which of these tests go with the screening, which of these tests go with the confirmatory test. Okay, because they'll ask you that. They'll say, what are the stages, or what is the progression? What do you do? This, then this, then this, okay? So know that. And this is kind of why you do it. You do this early syphilis, you do the NTT test. If it's late or reactivated, you could do the NT test or the TT test. Right, and then take your time and go through this, these different slides right here to know which one goes with which. Okay, if neither's there, then you didn't have it. If the TT's there, that means it's later on, right? So it's untreated, or it's more of a late syphilis. If they're both there, you still have the active form, but it's been there a while because the TT is elevated as well. And if the NTT is elevated, which is your screening test, right? But then you went ahead and did the TT test, then and it came back negative, is probably a false positive. Okay, so that's a good thing. But here's the thing about syphilis is all you have to give is penicillin, right? I used to work in the hospital. It's crazy that you just give penicillin and they come back and you'd find out, you'd be like, well, did you take your medicine? They say, yeah. And then they'd be like, well, did you tell your partner, did you give medicine to your partner? And they'd be like, no. And it's like, well, you kind of have to, like they have it too, right? So they have to take the penicillin, I don't know, put it in their food or something, but yeah, anyway. All right, HPV, right? You know about this. The warty kind 6 and 11, and then 16 and 18 lead to cervical cancers. Again, it's a very slow growing cancer. That's why you do pap smears and stuff to catch it early. Shoot, computer's acting up. Hold on one second. Let's see. Right, so know which ones go with which. The vaccine covers all 4 of these. I think some other ones too, 31 and 33. But so the main ones are covered in the vaccine that you get as a teenager. Yeah. Okay, so another thing they really like to test on is the way HPV works. The E6 inactivates P53, E7 inactivates RB. So that's why you get that overactivation and that unchecked proliferation. All right, so pap smear is very important screening test for that. All right, and Gardasil, that's the vaccine that they recommend. 3-dose vaccine, 2-dose vaccine, I guess, unless you're older. Yeah. All right. Lastly, herpes, genital herpes. Remember, these are painful, okay, versus syphilis or painless. So you can see this here, blisters form the non-envelope linear double-stranded DNA. So that class 1 can lead to itching. One of the buzzwords, this is specific for herpes, these Cowdery type A inclusion bodies can form multinucleate giant cells. Diagnosis, this is very important. This is what they use, this is the cells, these Zank cells, I don't know how to pronounce that, but that's specific for herpes. So you want to be aware of that. Gold standard, as with most things, just do a PCR. They're cheaper nowadays to just get a PCR. So just go ahead and do that. You can also use an ELISA test and whatnot. And then some of the small ones, I'm not sure we got tested on any of these. These came up. So if you want to go through these, you're more than welcome to, but I'm pretty sure we didn't get anything on that. All right, let's do, how are we doing on time? Y'all let me know if y'all want to break. I think we're good though, we can keep going. All right, uterine pathology. Right, normal anatomy, you know this by now. A lot of these things, as you would expect in the uterus, are estrogen sensitive. You know the phases now, that growth phase is estrogen, the secretory phase is progesterone, excuse me. So some definitions for you, but let's get into the pathology. Okay. Endometriosis, ectopic endometrial outside of the uterus. Primarily, we talk about those chocolate cysts in the ovaries. That's a big one. Yeah, you can see here, but you can get them otherwhere, uterine ligaments, septum, peritoneum, all over the place. But typically, they talk about it in the ovaries, kind of gives you these factors that are involved, misplaced factors. So those are kind of common things that go wrong. All right, so yeah, so if you do get growth in the ovary, it's chocolate cyst that will affect fertility, but this can lead to pain in the abdomen as well, stuff like that. And again, because it's endometrial tissue, it is responsive to estrogen, so you may get pain, in, where the ovaries are, in the lower abdomen to the side, around ovulation, right? Because of the growth and the ovarian rupture as well, follicular rupture. Adenomyocytes, so glandular, right? So tissue within the myometrium. So this is painful as well. You can see the chocolate cyst there. So endometrial tissue within the myometrium, this is separate. This goes with the previous one. They were talking about the growth in the endometriosis in the ovary. So now you can also get adenomyocytes. So endometrial tissue within the myometrium. Okay, so it's not supposed to grow deep into the myometrium like that. And this can coexist with endometriosis. But it can, this abnormal growth into the muscle can lead to heavy menses or irregular menses as well. Now, endometriitis is infection, right? So an acute infection, your normal things you expect, staph and strep. You can also get gonococcal and chlamydia infection if it ascends up. Chronic infection involves plasma cells. So good thing to know there. It's a diagnostic clue for chronic endometriitis or pelvic inflammatory disease. Okay, so you can get polyps. It's responsive to estrogen. Why would you use tamoxifen? Remember, tamoxifen is an antagonist at the breast and an antagonist in the endometrium. Okay, so if these polyps that grow are due to estrogen, if you can block the estrogen receptors in the endometrium, you can stop growth of these polyps. Okay, it says here adenocarcinomas can arise, but that's not very common. All right, then you get endometrial hyperplasia. As you would expect, this is due to estrogen, right? Typically, so prolonged estrogenic stimulation is important for this endometrial hyperplasia. That's the growth phase in the menstrual cycle. So if you get an excess estrogen for whatever reason, that could lead to hyperplasia. Okay, so they talk about things. One of the things that comes up is null-parious women, right? Why did null-parious women tend to get this more? Well, when you're pregnant, you don't have that estrogen stimulation for a number of months, right? So if you've never been pregnant, you're still in your normal cycle. So you're going to get this there's more estrogen around, so it's more likely you're going to get endometrial hyperplasia. Okay, but I've seen that in questions as well. So anytime estrogen is over and abundant, you can lead to endometrial hyperplasia. All right, so typical versus atypical. That's super important that I can remember. P10, tumor suppressor gene, is a common genetic thing, so I would commit that to memory as well. And you could see the atypical just looks more, the typical is more organized, and atypia, you can see here, pleomorphisms, irregularity. I mean, honestly, I would have to look at these next to each other to be able to appreciate a difference. If you just gave me one on a test, I don't know that I'd necessarily just be able to call this atypical, but anyway, it's there for you. All right, so then it can lead to endometrial carcinoma. You could see this, lose P10, KRAS, microsatellite instabilities, all these things are going wrong, and all of a sudden you use P53. A bunch of different things can happen, but that would lead to unopposed growth of these cells, right? And you have different types. So this type 1 is going to be unopposed estrogen problem and endometrioid morphology you can see here. So keep these separate. P10, KRAS, macrosatellite instability. These are all these perimenopausal around that age, but then postmenopausal, you're going to end up getting these serous endometrial carcinomas, and that's due to P53. So don't just assume that endometrial cancer is a premenopausal thing because it's all this estrogens around. You can get it postmenopausally, okay? You can see it's even more aggressive there. Right, and don't forget, I mean, even postmenopausal women, you have peripheral conversion to estrogen. So there is estrogen around, it's just not as abundant. All right. Good. All right. Endometrial carcinomas, evidence of DNA mismatch repair. We know mismatch repair has to do with Lynch syndrome as well. So yeah, sort of correlate those, I suppose. I don't know that that'll really come up. All right, then they go into some case studies. We're not going to do those. All right. So these different tumors, right? So let's see, endometrial tumors. So again, same principle. Again, cancer is probably one of the more difficult things to learn in med school. That's why doctors specialize, because they get good at, because it's so complicated, right? So we'll go through these, but same thing here. How do you diagnose it? What are some of the few characteristics of it? How do you differentiate it from something else? Okay, so leiomyoma is often called fibroids. You can see this development. They're also estrogen sensitive. These growths can affect fertility. So you can end up getting a hysterectomy if it's bad enough, if the pain's bad enough. But they are benign, smooth, they're encapsulated. So they have that very benign characteristic of it. Okay, you can see that here. This is growing into the myometrium over here. But again, you would expect it to be, this indolent appearance, right? This benign appearance, not a lot of atypia. It's very smooth and organized and encapsulated, but it's just abnormal growth. Leiomyosarcoma, so these are going to be more invasive, right? Because they're sarcomas, smooth muscle sarcomas, right? So they arise from the myometrium. They have malignant potential. You can see here they can go to lungs, bone, and brain. It's a big thing to remember about these. And let's see. Okay, so, right. The ecto and endocervix, right? And that junction line, that transitional, that squamocolumnar junction is a common point for abnormal growth, okay? This transformation zone that they talk about, you can see that here, the squamocolumnar junction. I think this is probably a high yield picture, and being able to identify this junction between the squamous cells and the columnar cells, right? So that junction is where a lot of growth, specifically HPV, grows. So when you do pap smears, you want to check that that transformation zone between the squamous and columnar junction. All right, and you can see this squamous metaplasia that grows there. That means the squamous cells are the new cells, the new metaplasia. So the squamous cells have replaced the columnar cells. That's how they write these. So you get squamous metaplasia. So the squamous cells should be in the ectocervix, the more protective barrier. The endocervix, it has that, it's supposed to have the columnar cells, more of a secretory cell. So if there's some sort of insult, these squamous cells can replace the columnar cells in the endocervix. So you could see that there, and that would be specifically response to irritation. So that's why you're getting growth there. All right, so cervicitis, some sort of cervical infection, as you would expect, gonorrhea, chlamydia, candida, trichomonas, herpes. We kind of talked about with the STI stuff. Okay, so being able to differentiate those by the type of secretion, the color of it, if it's the whiff test or the amine test, and the pH, right? That's an important factor. So go through the STI lecture again and look at the charts. All right, so, whoops. Sorry. I don't know why it won't let me go back for some reason sometimes, but, oh, there we go. Never mind. All right, so you get these endocervical polyps that can grow, mucus secreting, don't know that that's super important. Okay, these, these HPV warts, these type 6 and 11, remember you're worried about that transformation zone. Coilocytes are the name of the cells that develop. These warts are coilocytes. So if you see the word coilocytes, they're specifically referring to HPV. You need to differentiate those from those clue cells, which are specific for Gardnerella vaginalis. All right, then of course, anything in situ, however you pronounce it, those are going to be pre-malignant. They haven't gone through the basement membrane yet, right? So that's what you're looking at here. Specifically with those more invasive or more aggressive HPV type 16 and 18, 31, 33, you need to be able to monitor these. But as I mentioned before, this is a very slow growing type of cancer. So as long as specifically females get regular pap smears, this is not, it doesn't usually get to the point where they're invasive. You can see here, these are those coilocytes, right? You can see those. I think they do kind of look like clue cells as well. So be able to differentiate those when you see those pap smears. Or are these normal cells? Are these normal cells? I thought those were the coilocytes. Oh, here. Okay, don't quote me on that. Maybe that that's just the dye that they used for this. But it says normal. Okay, so hello? Yep.
Yeah, those are normal.
Those are normal. I guess what kind of, this is the specific dye that they use. That's interesting. I don't know. Anyway, okay. That's the specific stain.
Yeah, that's it.
Okay, great. Thank you for that. Right. So this is just normal cells. Those aren't necessarily those coilocytes. Okay. So you can see, of course, with any sort of cancer growth, you would expect increase nucleus to cytoplasmic ratio. Look how much space these nuclei are taking up there versus these over here. All right, I don't think this came up. These are other tests that you can use to look at the cervix as well. All right, and as you expect, look how big these nuclei are. They're taking up the whole space. They go from bottom all the way to the top. So if you differentiate these, obviously from left to right, they get more invasive. And then again, these cordyceps, which they gave a picture of it. All right, so you get these cytoplasmic halos. I guess you could search that on the internet and see what it looks like. But that would be indicative of HPV. All right, and they love testing that HPV E6 inhibits p53, E7 inhibits specifically RB, okay? And it can lead to cancer. Again, specifically, these four are the cancerous types. All right, can spread lung and liver, squamous cell, most common. And of course, anytime you see keratinizing or keratin pearls, you want to think of squamous cell carcinomas. Yeah, I guess if it gets bad enough, it can even block the ureters, right? So you get hydronephrosis, obstruction. So that's not good. All right. And adenoglandular carcinomas, again, 16, 18. That's what they'll probably ask you. All right, good. I will not be an OBGYN. I don't feel comfortable as much with this material as some of the other stuff. So thank y'all for bearing with me through this. This is as painful as me as it is for you guys. All right, so vaginal abnormalities, it kind of goes through these duct cysts, right? So Wolffian are the male, so you need to, the male portion so if you get these, those are supposed to involute, I believe, in females, right? So you wouldn't get those, I believe. Yeah, anyway, so these Gardner duct cysts are derived from these Wolffian ducts, or the rests, at least, where they used to be. And then glandular adenosis, you could see this. Sometimes DES was some sort of, they don't use it anymore, but back in the day, it was like some sort of estrogen that they used. So that people were, women in utero were exposed to this. You know, it inhibited the normal transformation of the vagina. So you get this adenosis, this glandular development. Not sure that was super important. Oh, and it did actually develop into clear cell carcinomas. Okay, but yeah, that was back in the day. I don't remember the 60s or so. Oh, there it says 70s and 80s. Yeah. All right. Yeah, I'm not even going to try to pronounce that. Yeah. Rhabdomyosarcomas, grapes, see those there. So not sure this was super high yield either. Squamous cell carcinomas, of course, you would expect 16 and 18, HPV infections. These are in situ, right. These Bartholian glands can get infected as well. So you get adenitis, this glandular infection. Abscess can form, same things you would normally expect, staph strep, gonorrhea, E. coli, and these duct cysts can develop. They can obstruct the ducts, okay? So you can get due to inflammation. Oops. All right, so this would be again from HPV, the 6 and 8, the low risk ones, the genital warts that can develop, particularly can develop in the cervix, but in the vagina as well. Again, you would see these cordyceps, this atypia. Leukoplakia, white growth. Remember, when you think of this white growth, a lot of times you think of candidiasis, but you can get that as well in the vagina. That can lead to a number of problems. Lichen sclerosis, see this in postmenopausal women, activation of T cells. So this is more of an autoimmune reaction. I don't remember any of this coming up in the test, to be honest with you guys, but hyperkeratosis, keratinization, white plaques, yeah. Sorry, I'm just reading off the slide. I don't remember any of this coming up. It's even in term 5, so All right, so squamous hyperplasia, you can see this here, leukoplakia, acanthosis or thickening of this layer here, hyperkeratosis. So acanthosis is the granulosa layer, I believe is this one right here. You can see thickening, and then hyperkeratosis can develop there as well. So it's just hyperplasia. It's not necessarily abnormal growth, just or abnormal cells, just excessive growth. And then Paget's disease can not only be in the breast, but it can be extramammary as well. So you can see this down here. And then carcinomas, squamous cell carcinomas can, again, the big thing we're talking about, HPV. That's the big one there, P53 or E6 inhibits P53. You can see spread where you would expect it, inguinal and pelvic nodes. Remember the outer aspect of the vagina drains to the superficial inguinal nodes. So that's what makes sense that they would spread there. Okay, so trophoblastics, so syncytio and cytotrophoblastics, remember those are always related to elevated beta HCG. So that's how you diagnose those. Hyetiform moles, this is more ringing a bell for me. This is something that they like to test on. You can see this grape-like clusters. That's what they talk about, this hyetiform moles. Increased risk of trophoblastic or invasive disease, or even leading to choriocarcinoma. Okay, so it can be complete or partial. We'll go into that, right? So the way I remember, so complete means it's completely from dad, okay? So you get 2 copies from dad. Okay, now with these complete moles, you're not going to get normal internal parts. You won't see any internal parts of the fetus. Okay, there's no mother component to it. You just use the mother's ovum, but you get 2 copies from dad. Okay, this is completely from dad and completely absent of internal parts. But you would definitely see an increased beta HCG way higher than a normal pregnancy. Okay, so a lot of times a female will come in, the urinary pregnancy test was positive, beta HCG was up, and then you actually check it in the hospital and it's super elevated, and then you're worried about something, one of these moles. Okay, so yeah, that's what you'd expect. That's syncytio and trophoblast, that's your beta HCG. That's what's forming it. Now, partial mole is going to be a triploidy. You get 2 copies from dad and 1 copy from mom. Now, with this, you will get fetal parts. Okay, so the partial is 2 copies from mom. I'm sorry, 2 copies from dad and 1 copy from mom, and you can see fetal parts. Okay, so definitely be able to compare and contrast the complete versus partial moles here. Again, beta HCG is very high. Okay, then it can also be invasive, which is not good. But because you have this cytotrophoblasts and syncytiotrophoblasts invaded in and of themselves, so if the mole is bad enough, it can invade even further into the myometrium. But again, the big thing you want to look for is this HCG elevation. Now, choriocarcinoma, again, increased beta HCG because it is a neoplasm of these trophoblastic cells. Okay, could be indicative of extra uterine ectopic pregnancy. If there's a history of pelvic inflammatory disease, you may get pregnancy in the fallopian tubes, ectopic in the fallopian tubes. Okay, right. All right, yeah. So yeah, I know that for that lecture, I would definitely know that those moles, being able to differentiate the moles, that would be the most important thing. All right, we have 1 more and 2 quick DLAs, and then we'll take a break and Lindsey can take over. I'm sure many of you could teach this contraceptive stuff and female anatomy and all this much better than I can. So again, we'll go through these. My knowledge of contraceptives is just what's on these slides, no more than that. So yeah, we'll go through it. So you see the normal ovulatory cycle. The goal here, you want to prevent that LH surge, right? So that's the whole thing. If you prevent that, you can prevent ovulation. So if you get a low level amount of estrogen or progesterone throughout the cycle, you prevent the spikes, there's no ovulation, and decreased risk of pregnancy. All right, so you can see the stabilization. You go through there. Right. same thing. So yeah, these you have combined pills, progestin and estrogen. I guess knowing these, what I put here is high, medium, and low. So androgenic effects. So norgestrol and levonorgestrel have androgenic effects, and then drospirenone has anti-androgenic effects. Okay, and then you can see these estrogens can be used as well. Ethinyl estradiol and mestranol, which is a prodrug of that. So combination pills, I know there's a million different things out there, but depending on some of these characteristics, like if you need to use the anti-androgenic effects, you can go with this one. But yeah, this is actually what, so like these little, what I put over here, which just correlates to this, like highest androgenic effects with these. Okay. Let's see. So some of the benefits of it, these oral contraceptives can decrease your risk of endometrial cancer, ovarian cancer. It could regulate your menstrual cycles, which is why a lot of females start it, and some of these other ones. All right, some of the problems, cardiovascular toxicity, it can increase the risk of blood clots as well. So you have to be aware of that when you do that. But yeah, thromboembolism. So if there's a history of emboli, a thrombus formation, you want to discontinue these. Also increased risk of obesity. I'm sorry, that the risk of these is increased by obesity, smoking, hypertension, diabetes, which would be expected. Yeah, one of the, yeah, right. So I think this came up. Migraines may be associated with cerebrovascular. So, you know, like stroke, not strokes, but yeah, well, you know, problems in the brain. So migraines can be associated with strokes or aneurysms or problems like that. So any women who have developed migraines should discontinue use. I don't think that's a very common thing, but for testing purposes, I would definitely make sure to know this. All right, some of the other things, progestins may cause insulin resistance. So if that's the case, if you're worried about that and type 2 diabetic or whatnot, maybe put them on an estrogen only pill, right? And we talked about the cardiogenic problems there. Yeah, and then some of these other ones, you know, these drug inducers, these CYP450s, rifampin. Yeah, so the way I remember is this CPR. It's really 2 Ps, but the major, these aren't the only ones, the major enzyme inducers, CPR, carbamazepine, phenytoin, phenobarbital, which are epileptic medications, and rifampin, which is used for TB prophylaxis or TB treatment, part of the regimen. These are inducers, so if you're taking estrogen pills or whatnot, it will rapidly metabolize them. So they will be out of your system very quickly. Okay, so you have to be aware of that. But the ones in red are the big ones, but there are some others, as you can see here. St. John wort is often used as over-the-counter for depression and whatnot, so you have to be aware of that as well. All right. Yeah, I know there's just a ton of different side effects. As you know, with androgens, estrogens, progesterone, there's a ton of different stuff. Now I put this on here, I put it in red, just because these are common things that they could ask you on the test, why you would want to completely take them out or completely contraindicated. Okay, specifically the migraines, that was a big one. Also, if there's any sort of history of thromboemboli, okay, or heart disease. So migraines, heart disease, you need to get them off of that. Okay, relative problems, says here migraine without aura, but the previous slide said history of migraine, discontinue, excuse me. So yeah, take that as you want. And then it talks about the progestin only pills, benefits of that, less effective when combined, right? You could use a patch. This is a combination patch. Ring, the implant in the arm, 3 years effective. And then the IUDs you can use. This is a progesterone IUD, 5 years, right? Injection. depot injection. Yeah, so they didn't really get into these different options and stuff. They basically just tested on what are the contraindications for it and stuff like that. Okay, and you can see the effectiveness here. They didn't ask us about anything like that. And then emergency contraception as well, the copper IUD used. And yeah, actually, what did they ask about this? Yeah, yeah, you should know this, right? So specifically progesterone, this is an emergency, emergency pill you could take after. Plan B as well, same thing, you're taking high doses of progesterone here. For that, same thing, progesterone. All right. And then quickly, we can go through this. Disorders of pregnancy. Big thing you want to worry about is preeclampsia, eclampsia, stuff like that can happen that you want to be aware of. Let's see, anything before 20 weeks, spontaneous miscarriage. A whole lot of things can go wrong before 20 weeks. So yeah, ectopic pregnancies, number one cause of that is previous PID, pelvic inflammatory disease. Usually lodges in the ampulla of the fallopian tube. So that's what you're worried about there. And then if that's the case, you can get a ruptured tubal pregnancy, a medical emergency. So you get that pain there. The pain because of the location mimics acute appendicitis if implanted on the right side. Okay, so you can see that, and you're worried about that ruptured ectopic pregnancy. The placenta abnormalities, yeah, so definitely know these. Previa is over the os, so you can't see it. Abrupto placenta, usually some, I don't think it has to be a traumatic injury, but it's an abruption, so you get a lot of bleeding if the placenta is torn off of endometrium. And placenta accretia, you can see here. I believe that is due to it. They should have a definition. I think the accretia is into the myometrium, if I'm not mistaken. Did they put? Is that correct? The accretia is where the placenta is in the myometrium. It goes too far. Anybody can look that up for me. Oh, here we go. Yeah. Yes, the villi go directly into the myometrium. So if that's the case, you're gonna, if you get to the point of pregnancy, it's gonna be hard for the placenta to be delivered because it's all the way attached deep into the myometrium. And when it does come off and it is delivered, you're at a risk for for bleeding, right? Bleeding after delivery, postpartum hemorrhage. Okay, so that's a big one. All right, so just having a good definition for these would be good. Then you get to eclampsia. Okay, so preeclampsia is defined by hypertension and proteinuria. Okay, you need both, but a lot of times that both of these will lead to edema. So you need to address the preeclampsia so it doesn't develop to eclampsia. If the patient starts developing seizures, that is a risk to both the child and the mother. So you're at full-blown eclampsia at that point. You could even develop what's called HELP syndrome, stands for hemolysis, elevated liver enzymes, and low platelets. Okay, so preeclampsia is defined by hypertension and proteinuria. If you start getting seizures, it's full-blown eclampsia. It's a big problem. You need to deliver the baby. Okay, I think that's all I had there. And then some of these drugs that we can use. We'll quickly go through these. All right, now cervical ripening, uterine stimulants, misoprostol. Remember that can be used as it's a prostaglandin analog. It can be used as an abortifacient, but it could be used for cervical ripening. So if it's time for the baby to be delivered, you can use misoprostol. It's to kind of relax the cervix for delivery. But if it's used as an abortifacient and you use it, it'll cause cervical ripening prematurely and deliver the baby prematurely. Okay. So yeah, knowing these prostaglandin analogs, ripening of the cervix, stimulate uterine contractions as well. All right, big one you need to know here is oxytocin. Oxytocin will cause contraction of the uterus. So if by giving that, it will induce labor, okay? Also, a big thing there is you can give that if there is postpartum bleeding, because contraction of the uterus will also cause contraction of the vessels, so that it will prevent hemorrhage, postpartum hemorrhage as well. Okay, so they use that a lot. As you know, coming from the posterior pituitary, it will also help with milk ejection. Okay, so milk letdown. Prolactin will help with milk production, and then oxytocin will have milk ejection. Okay, I know that. All right, again, postpartum hemorrhage is a big problem. So you can use oxytocin to kind of squeeze down on the vessels, ergot alkaloids, prostaglandins as well, okay? Oxytocin is first-line treatment, so that's the one you really want to give. Right. Okay, so tocolytics are something that's going to use to stop the contractions. Stop the contractions, okay? So before 37 weeks, preterm, don't want contractions, right? So bed rest, tocolytics, glucocorticoids can be given. As you know, if there is a risk and you need to deliver the baby prematurely, you can give glucocorticoids to help with surfactant production. You can give glucocorticoids to the mother, and that will help with fetal surfactant production, so the baby's not at risk of a respiratory problem, at risk of ARDS. So yeah, some of these you can give. They use mag sulfate a lot right before delivery. They're kind of waiting for the cervix to be fully dilated, so you can give mag sulfate in the hospital, and that will help to stop premature contractions until it's time. Indomethacin is prostaglandin antagonist, so it is an NSAID, not an antagonist. It prevents prostaglandin synthesis, so it can be used as a tocolytic, and nifedipine as well. Okay. All right, so primary, you could use magnesium sulfate. I was an ER tech. I remember they used to make me go around and with pregnant women and check their reflexes, because if you have too much magnesium or hypermagnesemia, you can get hyperreflexia. So I had to go wake all the pregnant women up and check their reflexes, because they were waiting to have their baby and to be dilated. And so they were giving them mag sulfate, and that was my job, to wake them up and check their reflexes. So back in the day. Anyway, all right. Yeah, you can cross the placenta, lead to respiratory motor depression, so use cautiously. Like we said, NSAIDs is the main NSAID, so to stop prostaglandin synthesis. So again, it's a tocolytic. And of course, prostaglandins will close that ductus arteriosus. So if you do give indomethacin, if you need to keep it open, if there's some sort of shunt that you need to keep the baby alive until they can have surgery. Nifedipine is that calcium channel blocker, and it can work as well. All right, some of these other ones, analog, I don't know that came up, oxytocin, terbutaline as well, tocolytic, let's say low yield. Yeah. Ortofactants, of course, we talked about mifepristone is an antiprogestin, and misoprostol is a prostaglandin analog. They use those together. Methotrexate is antagonist of, that's a cancer medication. It'll stop folic acid synthesis. That's an antagonist of folic acid. So you can technically use that too, but my understanding is they use this combination to reduce early abortions. Okay. All right. Well, that was good, I suppose. We could go ahead and take a 5-minute break, and then Lindsey will go ahead and take over for you guys.
Do you guys want to go ahead and finish up? I'm hoping to get through all of the endocrine stuff pretty quickly, maybe an hour. You guys know I talk kind of fast, but if you guys want to go ahead and get started, we can go ahead and get started. Okay, there's no objections in the chat. So I'm going to go ahead and get started for you guys. Have to get to the right spot. I did upload the slides. I've added a couple since I uploaded it, and I'll update it for you guys before everything is posted. I always sit here when Brady's talking and I'm like reevaluating all my stuff. So I added some stuff at the end. Okay, share this. Oh, my computer's being weird. You guys can see the DERS part 2 thing, right?
Yeah, we can.
Okay, awesome. Thank you. Okay, so part 2, again, I'm going to try to get through this. I condensed it down. So we're going to start with endocrine path. I think there were about 11, 14 questions on this. So starting with the pituitary, going down. The big thing with all of these diseases, of course, you know, you have hypo, and you're going to see signs and symptoms related to that. So when we're talking about pituitarism, you're talking about mostly just adenomas. And so they're just benign tumors. They can be functional, secretory, or non-functional. If they're secretory, you're going to see symptoms related to the actual hormone. If they're non-secretory, you are going to see more mass effects. So, you know, with a pituitary adenoma, you see the classic symptoms of, you know, bitemporal hemianopia, other vision changes, stuff like that. So that's what the non-functional ones are, but we're going to focus on functional right now. So prolactinoma, talked about that, you know, since term 2, galactorrhea, amenorrhea, sexual dysfunction, infertility, and then growth hormones. If you have an increase in growth hormone in kids, gigantism, adults, acromegaly. We've been over this before. A couple things I want to point out in adults. There is, other than kind of the quote unquote obvious effects, like direct effects of growth hormone, please note that it can also cause diabetes mellitus. And that's because there's an antagonization, you know, a big thing with growth hormone, you get that insulin insensitivity. And so you do have risk of diabetes mellitus. So make a note of that because it kind of seems ancillary to what we all think about with growth hormones. So just highlight that. And then hypopituitarism. So, you know, there's an anterior pituitary and a posterior pituitary. Anterior pituitary, you have cells that are both synthesizing and secreting the hormone. But with the posterior pituitary, everything's made in the hypothalamus, and then, you know, it's transported and then secreted. And so if you have actual pituitary dysfunction, you're most likely going to get anterior pituitary symptoms versus hypothalamus, you're going to get the posterior pituitary, and that's diabetes insipidus. So the biggest thing that, you know, we talk about all the time is Sheehan syndrome. So the reason why this happens is because there is essentially an enlargement of almost everything endocrine wise during pregnancy, but there's no increase in vascularization. So you increase size, but you don't increase blood supply. So you have a relative hypoxia, which is fine, unless after delivery you have a hemorrhage. So you are increasing the level of lack of blood supply, and then you can get infarction and shock or infarction. So essentially you are going to have, if a woman has Sheehan syndrome, you're going to have symptoms of defect in all of those hormones. So that's essentially it. I think for your exam, this is more going to be along the lines of diagnosing think that's going to be the biggest thing. If they ask something pathogenesis wise, it is going to be the, relative hypoxia, that kind of thing. And then diabetes insipidus, I focused at the level of pituitary because we are in the brain right now. I did not talk about nephrogenic because we're not in the kidneys, but this is ADH secretion. ADH is secreted in response to low blood volume. That's physiology. But what we're talking about here is lack of ADH secretion due to an injury to the brain. And so the receptors are fine at the level of the kidney, but you actually don't have the ADH. That's why an injury to the hypothalamus or pituitary is going to cause diabetes insipidus. How do you tell? After a water deprivation test, you're going to give the patient desmopressin, and if urine osmolarity does increase, then it's central. And then syndrome of inappropriate ADH. The biggest things here are what it causes. So it's going to lead to a euvolemic hyponatremia. And this is very rapid and very fast. And it's also very dangerous because when you have this hyponatremia, you get the cerebral edema, seizure, coma, neurodysfunction. A big cause that they love to focus on, paraneoplastic syndrome, small cell, squamous cell cancer of the lung. So those two things you need to associate with SIADH. It'll come back in term 5, but that's the big thing here. You know the definition, so be able to relate it to what's actually going to go on in the patient. So euvolemic hyponatremia, and then the paraneoplastic syndrome. Thyroid, I wasn't going to list out the symptoms of hyper. We've seen it since term 2. Hopefully we all understand the difference between the two. I put the first aid one on here, but be able to recognize this in a vignette, because they'll ask you questions about it, but just be able to recognize hyper versus hypo, and then they're not going to ask you questions about the symptoms. They're going to ask you questions about the actual pathology. So hyperthyroidism, all this means is that there is an increased level of T3, T4. That's what that means. At the very basic level, it's the definition, it's the level of T3, T4. TSH is the compensatory thing. Don't worry, if you're talking primary hypothyroidism, you're just looking at levels of T3, T4. That's it, stop there. Then TSH, if you see the compensatory mechanism, then it's primary. If you don't see the compensatory mechanism in TSH, then it's you look elsewhere. But so the ones we focus on, Graves, this is the auto antibodies against TSH. That's very, 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 very important. We were tested on it, I think, in ER, but how do you recognize the patient? You have this classic triad. So you're going to have hyperthyroidism symptoms. We are also going to have exophthalmos, which is classic to Graves. You're going to have the pretibial myxedemia, again, classic. And then you're going to have the goiter, the diffuse enlargement of the gland. And then histo, if we're looking at it, how are we going to recognize it? The scalloped appearance. Why is a scalloped appearance? Because we have that increased resorption of colloid, because we have that autoantibody that is stimulating the receptor. So the receptor is just being stimulated. You're getting that overproduction of T3, T4. And so you have this increased active resorption of the colloid. And that's why you have that scalloped appearance. So if you see that, that can kind of clue you in on it. They're probably going to test you more on like the autoantibody thing, or maybe like what is a feature that you would see in this patient. But I would say more the autoantibody thing, because that's classic Graves. And then a goiter is just simply an enlargement of the thyroid. It's kind of an umbrella of things. It's not just one diagnosis. What are things like you have impaired thyroid hormone synthesis, so you have compensatory increase in TSH, so then you're getting hypertrophy and hyperplasia of the gland. So that's the goiter, what we're talking about here. So we don't have the synthesis of thyroid hormone and you're getting the compensatory increase, but because of this compensatory increase, we can overcome the deficiency in the thyroid hormone. So it's kind of confusing. but the body is really saying, oh, we don't have this, so we're going to increase this, because if we increase this, maybe we'll get more like function out of it. And so you do get the function out of it. So you actually have euthyroid. And then mass effects, dysphagia, hoarseness, types, non-toxic versus simple, multinodular. How do you differentiate this from a neoplasm? A goiter is not going to have a capsule, whereas a neoplasm, you're going to be able to see that distinct capsule. Okay, hypothyroidism. Hashimoto's is the biggest one. The way you're going to be able to see this, you're going to have the classic hypothyroidism symptoms, and you're going to have a non-tender thyroid. So if you look at the next one, the dequervian, it has a tender thyroid. So Hashimoto's non-tender thyroid. This is autoimmune destruction of cells. Again, they're probably going to test you more on the serology of it. So anti-TPO is something that they love to focus in on for the Hashimoto. So focus in on that. Histo, you are going to have the dense mononuclear infiltrate. Another thing that you need to pay attention to, there is an increased risk of B-cell lymphomas with Hashimoto's, and then a characteristic histo thing to help you out there are going to be the Hurley cells. Now, dequervian, this is a limited hypothyroid, self-limited after a viral infection. So you know this is going to resolve on its own. And the way you're going to be able to recognize this, of course, the patient is going to be coming in and they have had some kind of infection in their immediate past, and then the thyroid is going to be very painful. So that's very different than the Hashimoto's. Still diffusely enlarged, and then histo, you're going to see the granulomatous inflammation, which is going to be characteristic for that. And then if you have subacute lymphocytic, so this is either autoimmune or due to natural immunosuppression. So non-tender, no enlargement, no Hurley, no fibrosis, no granuloma. So essentially none of the pathogen, the pathology that we see in the other ones. What you're going to see is lymphoid infiltrate in the thyroid follicles, which is going to cause the hypothyroidism, the decrease in function. Another cause of hypothyroidism, congenital. So you have multiple causes there. So with this, definitely focus in on Hashimoto's and Graves'. Those are going to be the biggest high yield points here, that, you know, and goiter as well, because you're getting that euthyroid. But these other ones, I know dequervian was a big thing in term 5. I don't remember it being a big thing in term 4, but definitely recognize the difference between those two in case they throw that at you on the exam. Okay, now we're just talking about the neoplasms. So presentations are going to be very similar. Again, a tumor in an area, it's usually going to produce very similar, you know, malignant symptoms. So we're focusing on histology and focusing on the specific characteristics. So adenoma, again, benign solitary mass. It can be hormone secreting, it could be non-hormone secreting. But the biggest high yield for the adenomas are going to be the hormone secreting ones. We already talked about the prolactinoma. We already talked about growth hormone. We're going to talk about a couple in a minute. But there are 4 kinds here. Papillary carcinoma, psammoma bodies, orphan antinuclei. The biggest thing for papillary carcinoma, risk exposure to ionizing radiation. This is a huge risk factor for papillary carcinoma. So if a patient has a history of ionizing radiation, focus in on that. But psammoma bodies are the biggest thing you're going to see with the papillary carcinoma, whether that be like they put it in the vignette and so you know what it is, or they put a picture, or maybe they are talking about papillary carcinoma. They talk about exposure to ionizing radiation, and then they're like, what's a characteristic feature? You can put psammoma bodies, and then of course BRAF mutes and RET or rearrangements. Follicular carcinoma, the biggest thing here, there's not a whole lot about this. But if they're talking about follicular carcinoma, I would assume that they would diagnose the patient for you and tell them it's follicular carcinoma and ask a characteristic. It's going to invade the capsule and vasculature. They might tell you that it invades the capsule and vasculature, but it's hematogenous spread. So those 2 things are huge for follicular carcinoma. It's the diagnostic feature of carcinoma, and it has to have this characteristic for it to be follicular carcinoma. So Most common are bones and lungs. And then medullary carcinoma from the C cells. How are we going to recognize this? They're going to call it sheets of polygonal cells. It does produce calcitonin, so you can check that in the serum. So those two things, the sheets of polygonal cells and the presence of calcitonin, those are something that they can put in the vignette so you can clue in on it. And then it's associated with the multiple endocrine, whatever it's called, the men. Don't worry about this right now. It's one of my last slides in the endo stuff. I have a super simple, quirky way of remembering it, and it'll get you every single question for the men questions. You're probably gonna have 2 or 3, but I have a super quirky way of remembering it, and it hasn't failed me yet. And then anaplastic is a rapidly enlarging mass. So that's going to be your clue in rapidly enlarging, and then you're just going to have mass effects, so dysphagia and hoarseness. Okay, adrenal glands. So I remember spending so much time in term 4 going over the dexamethasone test, and I memorized it and I kind of understood it, but it wasn't until term 5 where I simplified it and was like, oh, Lindsey, you're such an idiot. So Cushing's, if you come in with symptoms of increased corticosteroid levels, I put it on the next slide, but increased cortisol, you have truncal obesity with the what are they called, striae, all of those features of increased cortisol. They're not going to ask you about Cushing's. What they're going to ask you is what's the cause of it. So how do you know the cause? Well, you start with low dose dexamethasone test. So if the patient comes in and they're like, what's the first step? It's low dose dexamethasone test. And so this is simplified it. I highlighted it. This will get you 3 to 4 questions on the exam, easy. First step, low dose suppression. If you get suppression with low dose, it's either exogenous glucocorticoids or an adrenal tumor. So at the level of the actual adrenal gland. Easy. Now, if you do not get suppression with low dose, but you do get it with high dose, it's pituitary adenoma, done. You can do an MRI to confirm. You want to do an MRI because you want to look for that pituitary adenoma, but that's what clues you in on. If you don't have suppression with either, it's an ectopic ACTH. So those 3, memorize that. Super simplified. It'll get you about 3 to 4 questions on the exam. So now what are we talking about? Exogenous corticosteroids are going to cause a decrease ACTH, because if you're putting it in your system, you're going to have that negative feedback. It's like, okay, well, we have enough. Then you get to adrenal atrophy, because the adrenals, since we're not producing it in our body, the adrenals are going to atrophy, because if you don't use something, then it's going to go away. Now, adrenal adenoma, hyperplasia, carcinoma, all of these can cause an increase in cortisol, because the adenomas, remember, adenomas can be functional hormone secreting, negative feedback. We have too much cortisol. Okay, now we're going to decrease the ACTH, and then you're going to get atrophy from that as well. And then ACTH secreting tumor, this falls under the ectopic ACTH. And so this would be because of hyperplasia. This is perineoplastic syndromes. Remember, they love perineoplastic syndromes, small cell lung cancers of the lung, and then bronchial carcinoid. So make sure you still remember this. I would forget it. I would have to look at this every single time before we talked about lung stuff. The difference between perineoplastic syndromes of small cell and squamous cell. So make sure that you get that straight in your head. Don't take that for granted and then lose an easy point on the exam. But that's kind of it right there. It's not that, it's not as hard as we want to make it, or it's not as hard as I wanted to make it in term 4. But this is just the Cushing syndrome ones. I won't read that to you, but I just put it in there for completeness sake. And then adrenal glands. So we have hyperaldosteronism. So the patient's going to present with hypertension, high bicarb, hypokalemia, which makes sense because aldosterone affects this. And so you're going to have weakness, paresthesias, visual disturbances, tetany. Why? Hypokalemia. That's what that is in reference to. And then, so screening test, renin, confirmatory, you can use, and then CT. why CT can look for the presence of adenomas. And then but the big money, big money here is primary versus secondary. How do you tell the difference? Essentially, it comes down to the renin levels. Why is that important? Well, the adenoma is going to be secreting aldosterone. And so if we're already secreting aldosterone, we're not going to activate RAS. So there's no renin in the system. We are getting sodium retention, so you have hypertension, which is treatment resistant because it's not at the level of, scratch that, I don't know what I'm saying, but you're getting sodium retention, you have hypertension, hypokalemia, metabolic acidosis, and then secondary, this is an effective blood loss due to a different pathology. So liver cirrhosis, heart failure, nephrotic syndrome, anything that's going to have a blood loss. So you're activating RAS. So this is an indirect way to get the hyperaldosteronism. So activating RAS, and this does have increase in renin. So this point is something that clues you in on the cause, and they love to talk about this, and understanding why is really important, because that can maybe help you get a question or two here and in the future, if you just understand why the renin level is different between the two. Adrenal glands, some other things, Waterhouse-Friedrich syndrome. This is Neisseria meningitidis septicemia. So focusing on that. So it's adrenal crisis due to hemorrhage associated with this. So that's high yield. It's a buzzword right there. But how are we going to recognize the patient? You're going to see DIC with widespread purpura. The patient comes in and they are in a load of hurt, I don't know, but you have rapidly progressive hypertension shock there. But the Neisseria meningitidis is the big thing there. Addison's, progressive destruction of the cortex. So Addison's, I always remembered it as Addison's means all hormones are decreased. That's how I initially learned it. And it stuck with me. So you have chronic insufficiency. So this is a chronic insufficiency versus a more acute insufficiency. Of course, this is, a big disease. So chronic, so multiple causes, autoimmune, infectious is the big one. They love to clue in on TB. TB in the developing world, is a huge cause of Addison's disease or metastases. So what are we going to see? This is how you can diagnose the patient, or they may ask you levels. So hypotension, so it's hyponatremic volume contraction, hyperkalemia, metabolic acidosis. And then hyperpigmentation is the big thing here when you're talking about adrenal causes, is the hyperpigmentation here, because you're getting increased POMC, which breaks down into one of the products is melanin or melanin precursor, whichever one it is. Screening test, I kind of put that there for completion's sake. I don't remember that being a huge thing. They can put it in the vignette and it helps you recognize it, but you could also recognize it by the presentation. Congenital adrenal hypertrophy. I think that's what it's. I always abbreviate everything. Don't overcomplicate this. I remember spending so much time in term 2 trying to do this, and I finally in term 4 is like, oh, okay, this is so simple. So I think everyone knows the trick by now. If you don't, a 1 means increase. So first position, you're talking about blood pressure. Second position, you're talking about androgens. So how does this translate? If you have a 1 in the first position, it's hypertension. In the males, and then for androgens, in the males, you're going to see precocious puberty, and in the females, you're going to see ambiguous genitalia. Why? Because you have increased testosterone. So increased testosterone in the male, you're going to go through, it's going to kind of stimulate that. But with the females, you're going to have kind of a masculinization there. So you're going to have ambiguous genitalia because of the excess of testosterone. So people come in, if you see any mention of male precocious puberty, female ambiguous genitalia, then you know that there's a 1 in the second position. If there's hypertension, you know there's a 1 in the first position. So literally it's that easy. It may be 2 questions on the exam. It's not the most high yield thing, but it will get you a couple of points. Other things to focus on, you get an increase in 17-hydroxyprogesterone with the 21-hydroxylase deficiency, and increase in 11-DOC with 11-beta-hydroxylase deficiency. So that's pretty much it. Don't overcomplicate it. I mean, if you need to understand it, like spend as much time as you want on the pathology, but getting questions right on this exam, this is essentially the big points. Okay, neoplasms, adenoma, benign, again, can't type. We talked about that before. So carcinomas, so associated with hemorrhage, necrosis, anaplasia, it invades the veins. The biggest thing I could identify on here is that if it's inherited, associated with Lee-Fraumani syndrome. So again, big high yield, they love pheochromocytoma, chromaffin cell secreting catecholamines. What does this mean? You're going to see plasma metanephrines in the, you're going to see plasma metanephrines. So this is how you recognize the patient, or maybe they give you the symptoms and you have to say, okay, what are you going to see? And it's plasma metanephrine. So that's the biggest high yield here. Associated with MEN2A and MEN2B, this is high yield, but again, I have a trick to remember it at the very end that will hopefully get you all of the MEN questions on the exam. And then how do you recognize episodic hypertension and tachycardia? It's essentially all of the SNS symptoms. You know, the chromaffin cells are the post-ganglionic sympathetic cells. If that's wrong, you can correct me, I don't care. But yeah, just know what the chromaffin cells are and the plasma metanephrines and then its association with men. Then neuroblastic tumors, this is kids. So this is tumors of the sympathetic ganglia, adrenal medulla. So again, because we're talking about the ganglia, you're going to see the catecholamines, urine VMA, HVA, but you're looking for a kid at this point with the neuroblastic tumor. Now, endocrine pancreas, diabetes mellitus, I did not go really big into the differences between the two of these because we went really hard on this in term 2. And so I didn't feel the need to go through all of the physiology and everything there. So I'm picking out what I want you to focus on for exam purposes. So last minute, you're cramming. This is what I want you to focus on for exam purposes. Of course, go understand the pathogenesis or the physiology, not the pathogenesis, the physiology of everything. But for your exam, I'm going to tell you what I want you to focus on. So type 1, just the autoimmune destruction of the beta cells. It leads to an insulin deficiency. If they throw this at you, they like to associate it with Coxsackie B infection. That's a really big one, but also rubella, CMV, mumps. Then type 2 is peripheral insulin resistance and inadequate beta cell responses associated with obesity. So, you know, type 1 is more genetics based. Type 2 is more lifestyle based. So you're getting that peripheral insulin resistance over time, and then you can develop type 2 diabetes. But know how to differentiate between the two in a clinical presentation. But basis, both are going to present with polyuria, polydipsia, and polyphagia. That's the triad of diabetes. They're both going to present with that, and then they each have, you know, their own features. Complications, DKA, they love DKA. And remember, this is only with type 1 diabetes mellitus, only with type 1. And you're getting, so you have a state of insulin deficiency, of course, because of diabetes. So that leads to 2 different things, the ketones and then the osmotic diuresis dehydration. I wrote that out for you there, but the biggest thing to focus in on are the ketones and the osmotic diuresis dehydration. So the patient is going to come in with altered mental status, hyperventilation, which is Kussmaul breathing. The Kussmaul breathing, they'll probably define it as Kussmaul breathing for you in the vignette. But that is very characteristic respiratory pattern with DKA. And then anion gap is present, of course. And then treatment, you're giving insulin, and you also give potassium supplementation, because remember, when you give insulin, it's going to drive potassium back into the cell, and the patient can become hypokalemic. If you mess with potassium levels, it is really bad in the system. So you always want to make sure that it is within normal limits. So when you're giving insulin, you also give potassium, and then you give bicarb, because of course we are in a acidotic state. So you want to give bicarb. And then hyperosmotic syndrome. The diagnostic feature of this is the blood sugar level. It's wildly elevated. So altered mental status, and then the blood sugar level. So very severe dehydration. The biggest thing about this, your patient's probably going to come in, they're probably elderly, they probably had a stroke, or they just had surgery or an infection. Essentially, they are unable to keep up with the water consumption. Either they don't remember, or they're just not capable of getting water, or neglect stuff like that. But it's severe dehydration. So look for an elderly patient that just had a stroke or is disabled, or disabled in some way, coming in altered, and then the blood sugar is wildly elevated. Complications continued. You have advanced glycosylation products, accumulation of polyaryls. That's how you get the glaucoma, because I forgot what the process is. It's not the most high yield in term 4, but look over it anyway. Nephropathy. So the first sign of diabetic nephropathy, you're going to see them microalbuminuria, and then it's just a very common cause of end-stage renal disease. And then very high yield, they love to focus on this. Histo, you get the glomerular basement membrane thickening, mesangial widening, and tubular glomerular widening. So that's very high yield, focus in on that. And then of course retinopathy, neuropathy. Okay, parathyroid. The overview here, just make sure you understand this. This is very important to understand this, because if you can't remember anything just off the top of your head, understanding the actual action, it might help you get a couple questions right. So parathyroid hormone is secreted to maintain calcium levels. So again, calcium is another thing where if you screw it up really badly, you're very quickly going to see negative effects. So bone increases reabsorption and calcium release at the level of the kidney. You increase reabsorption, and then you decrease phosphate and bicarb reabsorption, increase calcitriol, and you activate vitamin D. And then the vitamin D is going to increase calcium reabsorption. So essentially, it's going to increase everything except the bicarb and phosphate absorption at the level of the kidney. So kind of easy to remember there. So try to simplify it down. The notes are kind of all over the place, and I had a hard time with this in term 4 because they are all over the place. Just simplify it. I've organized it in 2 ways, but this is a really good just graphical representation to kind of focus in on, okay, what's the cause of this? Because that's what it's going to do. They're either going to just give you a patient presentation and ask you what the cause is, or they're going to give you the presentation and ask you what the blood levels are, the labs. And so just break it down to the PTH level and the calcium level. But I've organized it by PTH and by calcium. They kind of do a mixture of the 2. And so I condensed it down to make it easier, because my brain could not wrap around how they were trying to organize it. So organized by parathyroid level. So hyperparathyroidism, all that means is you have an increase in parathyroid hormone. That's it. So primary hyperparathyroidism, again, if it's primary, it's secreting whatever it is. So why do we have this? Adenoma or just diffuse hyperplasia? Adenoma is going to be a tumor that's secreting it. Hyperplasia, you're increasing the functional mass of the organ. And so of course you have an increase in the hormone. Stones, thrones, bones, groans, and psychiatric overtones. And this is that comes from first aid. I think they put in the notes too. I don't remember. That's how you're going to diagnose the patient. So stones is, kidney stones, thrones is polyuria, bones, bone pain, I believe. But what are you going to see? Hypercalcemia, calciuria, polyuria, decreased serum phosphate and increased parathyroid hormone. That makes sense though, because since this is a primary PTH secreting tumor, it's going to do whatever PTH does. And so the cardinal effects of parathyroid hormone, you're going to see in the labs in primary hyperparathyroidism. Now, secondary hyperparathyroidism, you're not going to see necessarily the effects, because this is due to chronic renal failure. So remember, at the level of the kidneys, you're reabsorbing calcium. So it makes sense that if you have renal failure, you're not going to reabsorb calcium. Then you get hypocalcemia, and then you get that negative feedback loop. So you're increasing the parathyroid hormone. But again, you're still not going to increase that calcemia level, the calcium level at the level of the kidney, because you have kidney failure. So it's just kind of going to go around and around and around, but you're never going to get a significant increase in the hypocalcemia. So hypocalcemia, hyperphosphatemia, again, you can't, the kidney failure, if the kidney is responsible for removing the parathyroid hormone, decreases reabsorption of phosphatemia. So if we have renal failure, it's not going to do its job. So you have hyperphosphatemia. So it flips it. So you have increased parathyroid hormone. But when you think of the calcemia and the calcium and phosphate, they're going to be flipped. And then another lab that you need to be aware of is increased ALP. That's also primary hyperparathyroidism. And then tertiary, so this is still chronic renal failure, but you also have vitamin D deficiency. So now we're not just talking about we're not really talking about the kidney anymore. Now we're talking about the GI absorption. Because if you don't have vitamin D, you're not going to be able to absorb it at the level of the GI system. So parathyroid hormone is going to increase to, so the reason you're getting increased parathyroid hormone is to maintain normal calcium levels, because you're not getting that absorption. And then hypoparathyroidism, again, just decreased PTH. So there are many reasons for this. Congenital absence, autoimmune thyroidectomy, that's supposed to say hypoparathyroidism, pseudo hypoparathyroidism. Yeah. And then now I'm organizing it by levels of calcium, because when I approach these questions, the first thing, no, sorry guys. There's something in my background and it reset itself. I was watching The Voice before this and it resets itself every once in a while. That's why I just did that. Okay, where's my review now? Okay. No, that's not the right one. Where'd it go? Now I lost my window. No, come on. Here it is. Okay, now organizing by calcium levels. When I look at these, I actually look at the calcium level first, because that helps me clue in on what might be the case. So if we have hypercalcemia, it's going to directly translate to kidney stones, nephrocalcinosis, and muscle paresis. So I like this way of organizing it because calcium is very easy to identify as symptoms, whether it's low or high. So this is my favorite way of doing it, but I did both for you guys. So causes of hypercalcemia, primary hyperparathyroidism. Again, if you increase the parathyroid hormone, you're going to increase bone resorption. And so you're going to get increased calcium. Well, you're going to get increased calcium at different levels because you have the increase of the parathyroid hormones, but that's the big thing there. You can also get it because of malignancy. So if you have an ectopic form of PTH, then you're going to get all of the downstream effects of that PTH. So some that are associated, multiple myeloma, leukemia, skeletal mets, multiple myeloma. That hypercalcemia is actually is a cardinal feature of multiple myeloma. But we don't, yeah, that was hemonc. And so, but they might bring it back as like a cumulative thing or something. Another Paget's because you have increased bone turnover, and then vitamin D intoxication. Remember, vitamin D increases the level of absorption at the level of the GI system. So it makes sense that if you have vitamin D intoxication, then you are going to get hypercalcemia. Now, hypocalcemia, the symptoms that here are increased neuromuscular excitability and tetany. So how do you get this? Secondary hyperparathyroidism. Remember, this is decreased absorption due to chronic kidney disease, vitamin D deficiency, so you don't get the absorption, primary hypoparathyroidism, and then pseudo hypoparathyroidism. So the big thing here, be able to know the labs, and then be able to diagnose if you need to. Okay, now my super kooky trick. So this nice little picture is from first aid. I call it the men Venn diagram, but essentially what I did is I just shortened everything and put it into this little, I don't know what to call it. So in my head, the way I say it goes pink parathyphio-muke. I know it's dumb, it's weird, but it works 100% of the time. So I set this up. So if I recognize, okay, this is a men question, I open up my notes and I set this little sentence up right here. And then I just make circles. I make my little Venn diagram. And so I know which men it is. So men 1, men 2A, and men 2B. So men 1, you're going to have pituitary, pancreatic, and parathyroid presentation. So anything in there, like they can talk about anything in there, but if it's pituitary, pancreatic, parathyroid, you're talking men 1. Now, if they talk about parathyroid, thyroid, and pheochromocytoma, then it's men 2B. And then if they add in mucosal neuromas, then it's men 2B, men 2A, men 2B. I think I switched up the men 2s there, but simple and kooky, absolutely. But it's 100% effective if you're picking those out. So I did not understand it in term 4. I looked over that DLA for a really long time. I mean, it was one of those things that it was right before the exam. I was like, I'm going to take the L on this because there's just so much information. This is not what I want to cram in my head right now, but this is my way of doing it. Okay, so now we're going to go over some of the pharmacology. I was going through my slides and this is what I added. I broke it down. I didn't break it down as much as I usually like to, and then I figured out a better way to do it. And so we're going to talk about some of the big high yield stuff here. Pharm is actually very high yield on this exam. So we're going to go over some of this. And I know this is super messy, but I didn't download this. I was trying to find it in my files, and apparently somebody sent me this little review and I just printed it off without saving it. So I took a picture of all my little notes. So it's messy, I know, but I was looking at it, so many high yield points on just this one page. So we're going to go through it. I'm going to pick out some of the things I want you guys to write down and memorize. So when we're talking about treatment of diabetes, it's all about that HbA1c level, all about the HbA1c level. And so if a patient comes in, they start having symptoms of diabetes, you check the HbA1c, and then you decide what you want to do from there. So if the HbA1c isn't really elevated or just mildly elevated, you can start with diet and exercise. You can. But if diet and exercise isn't working and you have an elevated HbA1c, you can start with metformin as long as there is not a 1.5% increase above normal. So if it's above that, then you have to go to dual combination therapy. But as long as you're kind of within that elevated but not too elevated range, you can do the monotherapy with metformin, period. We'll talk about some things about metformin on the next slide, but that's the biggest thing, monotherapy right there. Now, if you can't maintain a decent HbA1c with monotherapy, you can add another. And so what you're going to add is a GLP-1 agonist. That's exenatide. That's what you usually want to add. So again, Start off with diet, exercise. If you can't maintain HbA1c, add metformin monotherapy. If you still can't maintain HbA1c, then you can add exenatide, the GLP-1 agonist. If you still can't do that, you can add another one. So that's kind of the basis right there of just maintenance therapy. And if there's any of you out there with diabetes, you could probably like teach this way better than I can. That's kind of the basis there. Now, there are other conditions that you have to go take into account within diabetes. Back up. If you still can't maintain, after a while, you're going to have to go to insulin therapy because you have a progressive destruction of the beta cells. And so remember, it goes over time, especially type 2 diabetes, you have the insulin resistance and it can get worse and worse and worse. And so you're going to get to a point where you have to go on insulin therapy because you just have to. But some things to take into account here when you're talking about insulin therapy are different conditions throughout the day. So when you do insulin therapy, you want that basal level, which is going to be the NPH. I forgot what that stands for, but that's your basal level. So you can start off with the low dose, single dose, but that's what they call basal insulin. Then whenever they say basal insulin, that's what they're talking about. They're talking about the NPH, and you can titrate that up. Now, insulin is secreted basally in kind of spikes too. And so the goal of insulin therapy is to kind of mimic that to coincide with consumption, food consumption. And so you have the basal level, but if you are having issues, you can do a long acting plus a short acting one at mealtime. And so the long acting one, you can either take right at bedtime or in the morning, and that gives you that basal level throughout the day that you have to maintain to make sure you don't tank. And then of course preprandial, you need to have that short acting to make sure you don't have spikes. And so if a patient comes in and they're diabetic and they can't maintain their blood sugar overnight, so they wake up in the morning and it's really high, or they have really high blood sugar before meals, then you need to get them on that long acting plus short acting. So long acting either at bedtime or in the morning, and then the short acting preprandial. I think it's the short, or not ultra short, but preprandial. So that's the big concept with the insulin there. So because they love those questions where a patient comes in and they have something about their blood pressure at a certain time of day and they're like, okay, what do you do? So just think about that, because you're actually trying to mimic the basal and the spikes throughout the day. And so that's what you're doing with the long and short acting insulin there. Then of course, some special conditions. If you have severe hyperglycemia, you of course have to do insulin. So this goes back to don't start with a non-insulin if the patient comes in and they have a severe disease. So you go straight to insulin. It's not on this slide, it's on the one that I didn't post on here. But if a patient comes in with severe hyperglycemia, you can't really do IV insulin. You can do glucagon. That's another factor that you need to take into account. And then pregnancy, insulin is going to be preferred here. And so again, I was already kind of talking about this, but this kind of mimics what I was saying is you're starting with the low dose bedtime NPH, so that's the basal insulin. And then if we're talking about postprandial, you're doing the Lispro aspart, which is the short acting, rapid acting. That's what it's called. I keep calling it short acting. I'm sorry, it's rapid acting. But that's kind of the basis for that. If you understand the insulin spikes and basal levels, you'll get a few questions on the exam. With the whole typical therapy, SU, they're probably not going to test on the typical therapy. What they're going to test you on are like the ADRs. And so I know this is a terrible quality picture, but I think this is actually in your notes. I couldn't find it scrolling through. So I took a picture because I actually printed this off when I was studying and I actually put it in my notes. But if a patient comes in and they have some sort of symptoms, they're going to start talking about the ADR. So metformin, the biggest thing here, you're going to have the GI symptoms and rare lactic acidosis and vitamin B12 deficiency. That kind of becomes like a red herring. I remember a small group when the patient had like vitamin B12 deficiency, but it was like, I don't know, it was a red herring. But again, metformin is first line monotherapy, but you're going to have a lot of GI side effects. So if a patient comes in and they have these GI side effects, it's probably metformin at this point. But if they have acidotic symptoms, yeah, it's metformin. But that's something that it's, while rare, it can tell you that it's metformin along with the GI side effects. Sulfonylureas, you have weight gain, but a big thing here is the risk of hypoglycemia. And so if a patient comes in and they're on a bunch of diabetes meds and you have hypoglycemia, it's probably a sulfonylurea. That's one of the bad things about it. And so that's a high yield point right there. That's one of the things that is bad about the sulfonylureas. The other ones, kind of basic, metformin and sulfonylureas are big ones. We talked about the exenatide. That's a big one. That's the GLP-1 agonist that they like to include on there. But go through these ADRs. When we're talking about these kinds of drugs, it's ADRs and mechanism of action. So that's what you want to focus on here. And then when you're talking about the insulin, you're talking about the actual course of blood sugar throughout the day and when you would go to insulin and when you would not go to insulin. That's kind of the basis right there. Oh, another high yield point. They always like to focus in on that. So I just pulled this off of Google. Make sure you understand which insulins go with which peak in this chart, and you'll get like a question or two on the exam. I started going through some other things, but I didn't finish it. So I'm actually going to finish this slide for you. And then you'll have it because I actually tried to break it down to how you would treat specific things if they came up. So I'll show you what I have so far, but I have a couple more points I want to add and I'll release it to you guys. But if someone comes in with growth hormone related syndromes, if it's low growth hormone, you can give a GH analog like somatron or somatriptan. If you don't have a response to a GH analog, then you can give mecasermin, IGF-1 analog. If it's high, choice is octreotide. There's another one that they list here, they list in the notes, but octreotide is way more effective than the other one. And so this is going to be the choice that they give there, and that's a somatostatin analog. And then prolactin related, symptoms of high prolactin are going to be infertility, sexual dysfunction, amenorrhea, galactorrhea, really annoying symptoms. And so if a patient comes in with infertility, low libido, they have amenorrhea, galactorrhea, you give them a dopamine agonist. So bromocriptine, carbogaline, cabergoline, I don't know how to pronounce it, but that's the treatment there. So I don't know if they would put both of them on the exam and give you a choice between them. I think they would just put one of the dopamine agonists on there. Yeah. So like I said, that's my last slide for you. Like I said, I'm going to add a few more points here because I was going through it, and the way I learned it is like, it wasn't drug, it was symptom, what drug you give. So I'm going to give that to you guys. More condensed, but that's it. Thank you guys for lasting this long. Good luck on your exam. You guys are going to kill it. We always say this, but you know way more than you think you do. So trust yourself at this point. Just, it is what it is.
Sorry to keep you guys longer, but can we go over the oral glucose test and the dexamethasone again?
Yeah.
Okay, thanks. I'm just curious about why with low cortisol or the low dose of dexamethasone, you would see adrenal tumors.
So if you
No, not the tumors.
Sorry, go ahead, Lindsey. Sure.
So it's not going to be the tumors. So if you have if you do not have suppression with the low dose, but you do with high dose, then you clue in on a tumor. And the reason is because if you have secretion of something, you can get that negative feedback loop. So it's not going to do it with low dose suppression because you're kind of just adding to what's going on. But if you have high dose suppression, essentially it's that negative feedback. It's like, oh crap, we have too much of this. We need to turn this off. So high dose suppression, it's stimulating that negative feedback loop. So whatever's secreting it, that adenoma, it's going to say, okay, no, we're like extra secretion. So you're going to turn off the negative feedback loop of the normal process. If you have low dose suppression, then you stop there because you don't need to go to high dose suppression. That's going to be exogenous glucocorticoids or an adrenal tumor. And then if you don't have suppression with either, it's ectopic ACTH. Did that make sense? Did that answer your question at all?
I'm still slightly confused why you get it is adrenal tumor, like I guess the physiology behind it.
Okay.
Of why, yeah, go ahead.
So the adrenal tumor is just producing a ton of cortisol, right? So when you think of the low dose dexamethasone, that's like, you're thinking about like in normal ranges. So like if your normal feedback loop didn't suppress it, this low dose dexamethasone isn't going to suppress it. You're kind of just telling the body, under normal circumstances, under this low dose dexamethasone, can you suppress the cortisol? If you can, then there's no problem. Everything's fine. But in the event you can't, that means something is making so much cortisol that it's overwhelming even the low dose dexamethasone. Because this glucocorticoid dexamethasone is acting like cortisol, right? So if you had increased cortisol, it should feed back on ACTH on its own. And that's the idea of the low dose, right? It should feed back and say, all right, bring the cortisol down. But if you had a tumor that's secreting a bunch of cortisol, like it's not going to respond to the low dose. So that's when you try the high dose. And then when you look at the high dose, you try to look at whether ACTH is decreased or not. Because if it's an ectopic, like some of those perineoplastic lung tumors, if it's atopic like that, it's not responsive to any sort of feedback loop. Okay, so it's just going to produce whatever it wants. But if under high dose conditions, you do get a decrease in ACTH, then you can identify it as, Cushing's syndrome, right? Yeah, so it's just a stepwise process to try to identify everything. But once you get the high dose, the main thing is to try to identify what does the ACTH do, because the high dose dexamethasone in and of itself is going to feed back on ACTH.
Yeah.
Mm-hmm. Okay, thank you.
And as for
Yeah,
the
and
oral,
at the end of, oh, go for it, Brady.
no, go ahead.
I was going to say at the end of the day, like understanding it is very important, but like right before the exam, if you're having issues with it, at the end of the day, the most important thing for this exam is just to be able to, off of the results of the dexamethasone test, what is the cause? So if you're still having trouble getting that, just essentially memorize it, quite honestly, because that'll give you a couple points on the exam.
Okay, thanks. And then I just have a quick clarification about the growth hormone and the oral test, the oral glucose test.
Mm-hmm.
I'm just confused. So we know that GH or the growth hormone blocks insulin. Yet if I give someone a little bit of glucose, you should see the growth hormone go down. But then if they have acromegaly, you should see no effect. And I just want to also understand the physiology.
So the growth hormone causes that insensitivity, insulin insensitivity. So go for it, Brady. Did you have to?
Yeah, so you have to remember with acromegaly, you just have an abnormal, like you're not responding to normal feedback loops. You're just not, because if you were, then you wouldn't get these elevations in and of itself. So if you are able to give glucose and it is able to suppress GH a little bit, that would indicate that you're under normal physiological conditions. So with acromegaly, these normal feedback loops are just not going to work. So even giving glucose is not going to, suppress insulin or anything in that regard.
So what is the relationship between growth hormone and there's a disconnect because it also says, growth hormone acts on IGF, and then somehow this is connected?
Yeah, so the growth hormone kind of has a two-prong approach. Like it has insulin-like effects in that you absorb, so insulin will help you absorb glucose out of the blood into the tissues. The way I think of growth hormone is everything, its whole job is to promote growth, right? So the insulin effects that it has is to take that glucose, bring it out of circulation and put it into the muscles and the bones so you can grow. But it also has other effects that are just that are not necessarily insulin derived, such as increasing gluconeogenesis. Like insulin doesn't do that, but growth hormone will do that because you want to increase glucose to increase growth. So I can't, I mean, I'm sure there was a slide where it had like this growth hormone, it had like 2 arrows and it had for insulin like growth hormone and then the other effects, but all of them made sense to me in regards to that. The whole goal was to increase the amount of glucose available and increase the glucose to the tissues, right? To promote growth, overall growth. So some of the effects are insulin-like, but some of the effects are almost anti-insulin-like, but all of the effects are in essence to promote growth.
I think it's also because, oh, sorry, just to add to that. So basically growth hormone has IGF-1, your insulin-like growth factor, right? So think about your oral glucose test. If you give a normal person glucose, what's going to happen? Are you going to get high insulin or low insulin? Normally, when you get glucose, you're going to get high insulin, right? So then insulin inhibits growth hormone in normal individuals. Now here in this person, what's going to happen is you're not going to get that suppression because they have a lot of growth hormone. So like, even though you're giving them an oral, like even though you're giving them glucose, you're supposed to get high insulin, you're supposed to get inhibition of the growth hormone. Does that make sense? I don't know if that helps.
Yes, it's just negative feedback pretty much. Okay.
Yes.
Right. Yeah. Just with these excess stimulation, growth hormone or cortisol or whatever, they just don't respond to negative feedback loops the way they should. So that's the whole goal in testing. It's like, can we see if the normal feedback loop works? If it doesn't, then there's something pathologically going wrong. Yeah.
So thank you so much, both of you.
No worries. All right. I guess that's it. Another term almost done. Y'all are going to do great. Just bear down a couple more days and y'all will be there. If y'all need any help, Lindsey and I are available. Just reach out to us. As I mentioned, next term, I'm going to be down here studying. So I do intend to do some reviews for you guys. So it's been great. We are very humbled to be able to do this with y'all. As I did mention this previously too, we get a lot out of doing these reviews too. So it's been great. Have a very Merry Christmas and you guys stay safe, and we will see y'all in January. Bye, guys.
Bye, guys.